Okay, so let's start with virtual lab. What do I
Boy
remember
50.
from my virtual
Hey, yo,
lab?
Travi, what's up?
Okay. This is useless. Let's go back to virtual lab. Change scale, show sinuses. Keep this open, we'll keep this open. And I will share my display. Okay. And triple screen. That would be good. Put this here, put this here, put this here. Okay. 25 days left. What did I get in my lab investigation? So I picked chemical pathology. I don't care about the slides. Let's get all the slides and get rid of them. And to move all of those in there. Alright, how do we measure blood glucose? What's the indications? Let's toggle it. Turn into toggle list. And move all of this in. Okay, so let's start with this. What are the indications for measuring blood glucose? So blood glucose can be used to, first of all, diagnose diabetes, where a random or post 2-hour oral glucose tolerance test result greater than 11.1 millimoles per liter is indicative of type 2 diabetes mellitus. It can also be used to evaluate the severity of hypoglycemia as a result of diabetes and monitor blood glucose levels throughout the course of a diabetic's disease progression. It may also be used to identify hypoglycemic states, so if a patient is extremely fatigued, and any other indications, we said diabetes, clinical symptoms, monitoring, and hypoglycemia. So that's the main things that we mentioned. So it's used for the diagnosis of type 2 diabetes mellitus, it's used for monitoring diabetic patients, it's used for hypoglycemia, and basically on clinical signs, if there is a patient who has polyuria, polydipsia, for example, to also measure blood glucose. Can you explain the different phases of blood glucose? So pre-analytic phase involves using a serum tube. So it means the pre-analytical phase involves time of day. Don't try to diagnose. Fasting is generally preferred. Let me get rid of that. Using any medications, steroids, blood glucose, and we can use a serum, a normal yellow top serum tube, and it depletes glucose by about 5 to 7% per hour, and we can use a fluoride tube which seizes metabolic processes and prevents cells uptaking glucose at the rate of 5 to 7%. In the analytical phase, we would centrifuge the glucose. It then undergoes spectrophotometry, in which we determine the absorbance reading based on the concentration of glucose in the tube. That is then compared to a standard calibration curve of standard glucose solutions of known concentrations, and we plot our absorbance value in this absorbance concentration of glucose curve to determine the glucose concentration in this tube. Now, we typically use light at 340 nanometers, and we're measuring, this light is ideal in measuring NADPH, which is a breakdown product of glucose, and the greater the glucose concentration, the greater the NADPH concentration. So that is how it works. NADPH, what's the chemical pathology criteria? HbA1c greater than 6.5, a fasting plasma glucose greater than 7 millimoles, and a 2-hour post oral glucose tolerance test greater than 11.1. And any random plasma glucose greater than 11.1 as well, in the context of glucose science. So let's start again. So explain chemical pathology. Can you explain blood glucose measurement? So blood glucose measurement involves consideration of the pre-analytical and analytical phases. In the pre-analytical phase, we would prefer to obtain a fasting blood glucose. We may also like to assess for any medications such as glucocorticoids, which may adversely falsely elevate blood glucose. In the analytical phase, we would begin by collecting our blood glucose in our typical yellow top collection tube. However, this may not always be preferred if time to analysis is long, as the cells inside the tube may deplete glucose at a rate of 5 to 7%. So we may rather prefer to use a fluoride tube. In a fluoride tube, the fluoride will seize glucose uptake by cells and thus preserve the blood glucose levels as it was in the patient's serum. In the analytical phase, we would begin by centrifuging the blood. We would then run spectrophotometry analysis on the blood glucose sample. This involves assessing the concentration of a breakdown product of glucose known as NADPH through using light that NADPH absorbs. We would first construct a calibration curve, and this is usually automated, where we have our absorbance and concentration of NADPH. And our calibration curve is constructed. This is way too long of an answer. I need 2 minutes to explain this. Explain how blood glucose measurement is taken. Blood glucose measurement involves careful consideration of the pre-analytical and analytical phases. In the pre-analytical phase, we might like to consider the timing of glucose. So fasting blood glucose is preferred over random blood glucose due to discrepancies in a postprandial state. We also like to consider medications a patient is taking. If they're taking glucocorticoids, for example, this may falsely elevate blood glucose levels. And then we can consider the analytical phase, in which we typically collect blood glucose in a yellow top bottle. We may prefer to use a fluoride bottle to prevent glucose uptake by existing cells, which can deplete blood glucose at a rate of 5 to 7%. The actual analysis of blood glucose involves 2 steps: centrifuging and then spectrophotometric analysis. So once the sample has been centrifuged, spectrophotometry involves... Oh, it's just too long, I need to time myself. Blood glucose measurement involves analysis at the pre-analytical and analytical phase. Reset. Blood glucose analysis involves 2 key steps. There is centrifuging and then a spectrophotometric analysis. Prior to the analytical phase, in the pre-analytical phase, we may like to consider whether we'd like fasting or a random blood glucose, with the former being preferred. We may also like to consider the type of tube would be used for collection. You could use a typical yellow top, however, a fluoride tube prevents glucose uptake into cells, which can preserve blood glucose levels, as it were, in the patient's plasma. So once we've centrifuged the blood glucose, we can then undergo spectrophotometry. So this involves plotting the absorbance that glucose sample has generated against a standard calibration curve. And the calibration curve is constructed by measuring the absorbance of predetermined standard solutions of a substance known as NADPH, which is a breakdown product of glucose. What we can then do is shine light at approximately 340 nanometers through the actual experimental sample, and we would measure the absorbance. We use 340 nanometers as this is the peak absorbance of NADPH, the breakdown product of glucose. We then get our absorbance value. We can plot it in our absorbance concentration graph to determine the concentration of blood glucose in the specimen. And this is used for diagnosing diabetes. It's used for monitoring glucose control and investigating hypoglycemia in patients who are symptomatic of hyperglycemia with symptoms such as polyuria. What is the chemical pathology criteria for diabetes? a random blood glucose level of approximately 11.1 millimoles per liter is diagnostic for diabetes. A random HbA1c, which is measuring glycosylation of red blood cells, can provide an accurate 3-month average of blood glucose control. And a value greater than 6.5% is indicative of type 2 diabetes. And a fasting blood glucose greater than 7 millimoles per liter is indicative of type 2 diabetes. And as we mentioned, random blood glucose and a 2-hour post-OGT result of greater than 11.1 millimoles per liter is also diagnostic. Tell us about troponin. Troponin can be used to investigate and is involved in the diagnosis of patients with a myocardial infarct, where a positive troponin can indicate there is myocardial necrosis and thus be used to determine a STEMI and NSTEMI, in addition to the clinical presentation, ECG findings. Troponin is a complex of 3 proteins, is troponin T, C, and I, that's present on the surface of the sarcomere. Troponin C is also present in skeletal muscle, and hence it's not used for specific evaluation of myocardial infarct. However, troponin T and I may be used. But what does troponin specifically do? Is a sarcomeric calcium regulator. Unbinding calcium, troponin transmits information affecting ATPase activity. Tropomyosin. Troponin and tropomyosin. The troponin complex is a component of the thin filaments in 3 types: troponin C, troponin I, troponin C. The troponins are 3 different proteins which are structurally not related: cardiac troponin and skeletal muscle. But how does troponin work? Tropomyosin covers the myosin binding sites. Troponin complex holds tropomyosin in place, and calcium-active troponin causes tropomyosin to shift, to expose the actin binding sites, and it enables muscle contraction. It's involved in the regulation of contraction. What is troponin? Surface of the sarcomere that regulates muscle contraction. Calcium binding to troponin enables it to remove tropomyosin, exposing myosin binding sites to actin. This enables muscle contraction. Okay, so let's reset this. So tell us about troponin measurement. So we'll start with this. How do we measure troponin? It involves a sandwich immunoassay technology in which we have streptavidin coated particles bind to. We have capture antibodies, so streptavidin binding to the biotin. The biotin binds antibodies. We also have a signal antibody and chemical pathology. Sandwich immunoassay. Activated with 2 antibodies. We have a streptavidin bias antibody complex and signal antibody sandwich. They sandwich the troponin and sandwich phenomena generates light, is detected to determine troponin levels. And once triggered, we remove capture into solid phase. Sandwich troponin into a solid phase, and then the sandwich phenomenon generates light. Light determines troponin levels. Exogenous biotin. We can have antibodies that also appear structurally similar to troponin, and they can occupy troponin's position, and macrotroponin can complex and persist in serum for longer and result in a falsely elevated result. What if troponin is negative? You must correlate with the ECG. So you must always correlate with the clinical presentation of the patient, and if it's ECG and if it's negative, you can repeat, looking for an increase of greater than 5. Troponin value greater than 5 nanograms per liter is a positive result. So we'll start again with our answer. So what is troponin? How is it measured? Well, troponin is a complex of 3 proteins, troponin C, I, and T, that's present over the sarcomere, and it regulates muscle contraction, and calcium may bind to this complex, enable movement of tropomyosin, which can expose the myosin binding sites to actin and enable muscle contraction. Troponin C is also present in skeletal muscles, so we focus our analysis on troponin T and I, which have very similar sensitivity and specificity for identifying cardiac damage. We measure troponin using a sandwich immunoassay technique, and this involves using antibody that is bound to a biotin streptavidin complex, and this will sandwich the troponin molecules against another antibody that has a fluorescent or light signaling molecule. This sandwich of the troponin forces the troponin into a solid phase. We can wash away any other reactants, and we then will see light being produced that is detected and correlated to determine the troponin concentration. Common sources of interference with the troponin assay can involve, number one, we may have exogenous biotin if the patient is taking biotin supplementation, and what this may do is bound that streptavidin complex falsely, and that can affect our results. We may also have heterophile antibodies, so the patient may have other antibodies that appear structurally similar to troponin and may occupy that sandwich site, falsely elevate troponin. And we may also have troponin molecules that may aggregate with other serum antibodies, form a complex with longer half-life, and thus persist in the plasma, and this causes a falsely elevated troponin result. That was 2 minutes. Let's correlate. Heterophile macrotroponin complex. What is troponin? We've done that. What about microbiology? Let's get that down pat. What are the indications you can assess? Let's start with urine MCS. What are the indications? UTI, STI, or a delirious patient. 3 indications for a urine MCS. We obtain midstream, right? Got this. Need to go back. And do we do midstream? Midstream is for, so the initial stream will flush out in a urinary tract infection. So first stream would be important for STIs. disease. Then I have done not even ovarian carcinoma. Surely there's biomed. Ophthalmology, infectious, gastrointestinal, path, colorectal, fever, pancreatic cancer, what are diagnostics? Glycophilic liver disease, pelvic inflammatory disease. So what investigations would we perform? We'd get a first catch urine because that will flush out, and a midstream urine would get. So the first catch will look for STIs that might be present in the urethra, and then your midstream is for UTIs, and that's because present in the urine. So there's already present STI microorganisms in the urethra. So when you flush that out, the first catch will look for STIs, but the midstream will identify UTIs, which are actually present in the urine. So it's midstream for UTIs. We'd collect a midstream sample, and for an STI screen, we would collect a first stream sample. Okay, and then delirious patients, what's the method? We obtain 1 microliter of the urine, we get the patient to complete a midstream urine. Wash your hands, remove the lid, hold the skin folds apart while avoiding the genital area with a towelette, a small amount urine into the toilet. Wash your hands, clean the genital area with tissue paper or warm water. From the front to the back. Boy 50. Then you pass the urine. Be at least a quarter full. The final part. Then touch the inside of the container. Menstruating. Insert a tampon for urine collection. That's what we need to do for a method of collection. Instruct and menstruate urine. Urine MCS, stream urine instructions, urine instructions. So, instruct the patient to do the following, delete. Okay. Method, we get 1 microliter, we can pipette it into grids. And then we microscopy looking for red cells, white cells, squamous epithelial cells, and bacteria. We may not always need to do a gram stain, as our specific biochemical assays can determine what the specific bacterium is. And it's used more for quantification, and sometimes gram stain is not performed. We can then proceed to a culture, and we can use a split plate with 2 different cultures, approximately 35 degrees for 24 hours, and we use horse blood agar, and then we can use a chrome agar on another side. So the split is, number 1, we have horse blood, and we have chrome agar. Differential chrome agar. Differential chrome agar contains enzymes that produce unique colors. We can then, after our culture, we can obtain is indole, catalase, coagulase. So we can use a panel of approximately, what does API panel even stand for? API. Analytical Profile Index Panel. API. Or analytical, is it? Profile index. Profile index. Right, we run it through an API panel. It's an analytical panel index. And it's a series of 20 biochemical tests, and then we can run it through MALDI-TOF, which is matrix assisted laser detection, desorption ionization, time of flight. Okay, so they're exposed to laser technology and it produces a cloud of vaporized particles or proteins that can be analyzed via a mass analyzer and an ion detector to determine the specific proteins present, the profile. And then, so we've done microscopy, it's number 1. 2 is culture, 3 is biochemical identification, and that's using a series of approximately 20 biochemical texts, and then a MALDI-TOF to look at the protein profile by a mass analyzer and ion detector. And then we can run sensitivity, so that involves getting that culture, stabbing a fresh colony, inoculating it into saline, and then squirting that saline, inoculating it into a dried plate, distributing the inoculum, draining the excess, and then placing 6 equidistant antibiotic discs and incubating. And it takes another 24 hours. And then we can also measure the minimum inhibitory and minimum bactericidal concentrations. And can also provide information on potency, and then we can consider blood culture. Those are my 2 technologies. Right, so let's start again. Tell us about the urine MCS. The urine MCS is used in order to assess delirious patients, patients with UTI or an STI. The first involves collection of a urine sample. This could be the first stream urine in the case of a sexually transmitted infection, or a midstream. Okay, urine microscopy culture and sensitivity is conducted for patients with suspected urinary tract infections, STIs, or any delirious patient where we suspect UTI can be the cause of delirium. The sample is first collected through a urine bottle, and we can collect a first stream urine in the case of STIs, or a midstream urine. And following this, we'll obtain 1 microliter and pipette it onto grids. And our first step microscopy involves quantifying the different types of cells and their relative quantity. So this involves white cells, red cells, any squamous epithelial cells, which could indicate contamination. And typically when we see white cells greater than 10 to the power of 8, or 2 different white cells that have a very high prevalence, this could indicate a urinary tract infection, and there may also be a high number of polymorphonuclear cells on microscopy. Sometimes we may gram stain, but this isn't always required, as further biochemical tests will identify specifically what the pathogen can be. We will then culture the pathogen. This involves using a split agar that has horseblood agar on one end and differential chrome agar on the other to identify specific organisms. We can then run a series of biochemical tests using API analysis or MALDI-TOF. The culture usually takes about 24 hours, and following the culture we can conduct those biochemical tests. MALDI-TOF involves laser technology which vaporizes a bacterial sample and produces a protein cloud in which we can detect its mass and ion chemical profiles to identify the specific bacterium. We can then do sensitivity analysis, which involves placing the bacteria in a separate agar plate with saline and equally distributing the inoculum of bacterium saline, and then placing 6 antibiotic discs that are equidistant from one another and measuring the zone of inhibition. And we can also, this takes another 24 hours, and we may also be able to obtain the minimum inhibitory concentrations and minimum bactericidal concentrations from this. Start again, that was too long. Urine microscopy culture and sensitivity is indicated in the event of a urinary tract infection, a sexually transmitted infection, or even potentially a biliary patient we suspect UTI as a cause. We would first collect a sample of the urine using the sample cups, and it could be a first stream or a midstream urine for an STI and UTI respectively. The first step involves microscopy, where we obtain 1 microliter, we pipette it on a grid, and we microscopy identifying different cells and their relevant quantities. And typically greater than 10 to the power of 8 polymorphonuclear cells could indicate infection. And if we identify greater than 10 to the power of 8 units of bacterium, that could also indicate an infection. Stop right there, is that right? It's a method. This is what I need to mention if I am correct. Kidney injury, urinary tract infection, why is a midstream taken? It's normal flora, it's microorganisms. 2 hours, start 4 degrees up to 24 hours. And for room temperature, microflora, it's positive. Can you test an MSU? Appearance, you can dipstick the midstream urine, do an MCS. Okay. If the UTF, there are 10 to the power 8 microorganisms per liter. Okay. Causative agents, E. coli, Staph, saprophyticus, to the power 10 microorganisms per liter. So treatment. Cefalexin, augmentin, nitrofurantoin, trimethoprim. And how do you conduct sensitivity testing? Use a disc diffusion test. We can also select antibiotic and incubate test tubes with varying antibiotic concentrations, and we can also get minimum inhibitory. Okay. Dilutional testing, disc diffusion testing. That's number 1. The disc diffusion test, and we can also use dilutional testing. Dilutional testing. Testing with varying antibiotic concentrations. Okay, so dilutional testing, we can use dilutional testing when we incubate the antibiotic, incubate test tubes, incubate sample with test tubes of varying antibiotic concentrations. Varying antibiotic concentrations. Okay, so Can you explain the methodology for a microscopy culture and sensitivity? So microscopy culture and sensitivity is indicated for UTIs, STIs, potentially patients with delirium. And the first step microscopy involves pipetting 1 microliter of urine collected from a sample of urine and observing for the quantity of and identity of various cell types. So we can assess for white cells, red cells, polymorphonuclear cells, which are a subset of those white cells, and also the microorganism itself. And a UTI may be suspected if there are greater than 10 to the power of 8 microbes per liter in the sample. We can then proceed to culture. And culture typically takes 24 hours and involves a split plate of horseblood agar and differential chrome agar. And this can be used to identify specific types of organisms. Following the culture phase, we may then undergo biochemical testing, and this can be done to specifically identify the type of bacterium. This can be done through API analysis, which involves a series of biochemical tests such as coagulase, catalase, indole testing, and we may also consider using MALDI-TOF, and this is our main way of biochemical analysis. And MALDI-TOF involves laser analysis and vaporization of a sample of urine, and that sample can produce a cloud of protein which is assessed for the ion profile and the mass profile, and this can determine the specific type of bacterium. We can then proceed to sensitivity analysis, and this can be done via the disc diffusion test, where we inoculate another agar plate with the sample evenly, place 6 equidistant antibiotic discs, and measure the zone of inhibition, where greater than 6 millimoles is indicative of bacterial sensitivity. We can then also proceed to the dilutional testing, which involves placing the samples in varying test tubes of antibiotic concentration, and this can be used to determine the minimum inhibitory and minimal bactericidal concentrations. Blood culture.
JK, really? Hey, yo, Travi, what's up?
Okay, what about blood cultures? What are the indications for a blood culture? A blood culture may be used to assess for septicemia. It may also be used to assess intravascular infections, for example, an infective endocarditis, and potentially also infectious emboli. And the key considerations in taking a blood culture involve aseptic technique, so cleaning the bung with alcohol and ensuring the alcohol is fully dried, and that's the top of those culture bottles. We must also take sterile technique when prior to obtaining the blood from the patient's skin, so we can wipe with alcohol, wait for drying, and we may also want to consider the order in which we use the bottle. So typically the needle has some air, and thus we might like to put the blood collection in the green tube prior to the orange tube. And then volume is also important. We need good quantity. Say what? Ideally 10 ml in each bottle. Need at least 5 ml in each bottle. Aseptic technique, alcohol, and yeah. So what are the overall steps? And then it's analyzed by a Virtuo machine. If positive, medical professional is notified, and then it's gram stained to determine whether it's gram positive or negative. So so it's through Virtuo machine, it's gram stained. And if we need to microscopy gram stained, and we can potentially culture, and so we can culture a heavy inoculum, so it can be under culture. And then after 4 hours we can run the biochemical tests such as catalase, bile esculin, so it can determine between Enterococcus and Streptococcus. That tells me Enterococcus is gram positive, and black discoloration. What is the gram staining of Enterococcus? Yeah, It's gram-positive cocci. They often occur in diplococci, so it looks very similar. It can look similar to streptococcus, and thus we can do a bile-esculin test in a darkened color. You can use a catalase test, and then you can incubate overnight, so that takes 24 hours. So culture and then sensitivity takes another 24 hours. It's a different test tube. And we use varied antibiotics. So the difference here is microscopy, we always gram stain it, and this is only if it's positive. It's analyzed and further analysis. So we then can undergo microscopy. So we can then undergo microscopy, and then we can undergo culture. We can do a heavy culture and then Maleditov analysis, in addition to biochemical tests, and then we can do sensitivities. So if the difference is you do gram stain, and before we even analyze a specimen, we run it through a Virtuo machine. Okay. So start again. Let's start again. So can you identify the key indications for a blood culture and the methodology for cultures? Blood cultures are typically taken when we suspect there is a septicemia, so a febrile patient that may have evidence of sepsis, potentially septic shock. We also like to assess for intravascular infections such as endocarditis, as it's part of its diagnostic Dukes criteria. The key considerations involve maintaining aseptic technique in the order of filling the bottles and ensuring we obtain a satisfactory volume, typically 5 ml in each culture bottle. Aseptic technique is specifically indicated for the tops of the blood culture bottles. They must be cleaned with alcohol to dryness, and the same for skin. We would also like to obtain at least 5 ml for use in each culture bottle, and the order of filling is important as the green bottle is aerobic, and thus we would not want to introduce air. We would not want to introduce air, which is typically at the end of the needle, into the anaerobic bottle. So the overall steps involve, first of all, obtaining the blood culture sample, so at least 5 ml using aseptic technique in each bottle. It's then run through a Virtuo machine in which it is automated and analyzed repetitively for a positive result, which indicates microbial growth. If microbial growth is identified, then the health professional is notified who ordered the test, and there will be further testing done, and this is through microscopy, culture, and sensitivity. The microscopy process involves additionally gram staining to determine whether it's gram positive, negative, in the case of Staphylococcus and Streptococcus, or negative organisms such as E. coli. We would then like to culture the organism, and given the time taken for culture, we may like to do a heavy inoculum and then follow this up with biochemical testing in Maleditov to identify the specific organism. And then finally, we would proceed to sensitivity analysis, which can be done using the disc diffusion test, where we inoculate another agar plate, and this typically takes 24 hours, where we measure the zone of inhibition when equidistant antibiotic discs are placed. We would use a different set of antibiotics to your urine microscopy and culture, and this is due to the fact that septic infections are caused by different causative organisms and require different antibiotics, potentially via the intravenous route as well. Okay, so I've got my ChemPath, got my microbiome. So TLDR, the glucose is done via a sandwich immunoassay technology. So glucose is centrifuging and spectrophotometry, microbiology is microscopy, culture, biochemical testing, and then sensitivity analysis. So I've got all of that. So let's start doing cases. what haven't I done? Endocrine farm. Let's smash this case out. It's 8 minutes, right? So let's see how I go for types of medications. What? That moved. Let's just quickly revise this so I don't get stuffed. Alright. So medical treatment, biguanides, hepatic gluconeogenesis, increased peripheral sensitivity, equals lactic acidosis, nausea, vomiting, diarrhea, renal hepatic impairment. Your glitazones are PPAR alpha agonists, bind to nuclear receptors, increase transcription, and they decrease hepatic gluconeogenesis and increase insulin sensitivity. They can cause weight gain, peripheral edema, and can also cause headache as well. How I remember the headache. Glitazones. Glitter. I think aura, headache, glitter. And you get pedal edema, weight gain, headache, and it can cause osteoporotic fractures. I remember that. So don't use it in pregnancy. Sulfonylureas is the second line. They bind to potassium sensitive ATPase sensitive potassium channels, and they can increase potassium, bind to ATP sensitive potassium channels, and they can cause depolarization, which causes, but if you open the potassium channels, there'll be efflux of potassium. So why do we get sulfonylureas? Mechanism of action, let's have a look. So it's going to, sulfonylureas binds to the channel, prevents potassium efflux, and thus can cause depolarization, calcium influx, and insulin release. That's a perfect image. We'll add that. Further notes. Toggle planets. Notes. We'll call this sulfonylureases, and we will then call it glitazones. No clue how these glitazones work. Thiazolidinediones. Thiazolidinediones. Okay, what does it do? Efficacy, edema, weight gain. Edema, weight gain. Wikipedia, you about to help me out. They activate peroxisome proliferator activated receptors and the nuclear receptors, specifically PPAR gamma, and they bind to DNA, bind to the retinoid X receptor, increase transcription, and the main effect is an increase in the storage of fatty acids in adipocytes, thereby decrease the amount of fatty acids in circulation, as the cells dependent on glucose, decreasing glucose levels. And they also decrease triglycerides and so it decreases gluconeogenesis. That makes sense. So your glitazones are PPAR agonists, and this is peroxisome proliferator activated receptor, and specifically it's the gamma subtype of this receptor. They're PPAR agonists, and they bind glitazones bind to these receptors, and they cause increased transcription of genes. And this results in increased storage of fatty acids in adipocytes. So that causes the side effect of weight gain. Side effect of weight gain. And there is thus increased reliance on circulating carbohydrates, decrease blood glucose. Why would that decrease gluconeogenesis? Why would that decrease gluconeogenesis? That's my question. Okay, p-power alpha also is the same as metformin, decreases gluconeogenesis, and increases peripheral insulin sensitivity. And it also causes edema, so you would not want to use it in cardiac failure, for example. Glitazones manage medical treatment. Glitazones, sulfonylureases, and creatine mimetics such as exenatide in pancreatitis and hypoglycemia, and same with DPP-4 inhibitors. Because they act in the pancreas, these GLP-1 agonists will go and bind to the pancreas, and it can GLP insulin secretion from the pancreas. And alpha glucosidase inhibitors, and then your SGLT2 inhibitors. What are your targets? Don't give thiazide diuretics for less than 65. What are your targets? How would you manage? So we said 4 to 8, and then 10, and greater than less than 7. That's our targets. And how would you manage diabetes, lifestyle, pharmacologically? And then for type 1 diabetes, we use a basal bolus regimen where there is a basal, intermediate to long-acting insulin, and then prior to meals, we can use a rapid-acting insulin such as Novorapid, which acts extremely fast. And the way we get these is recombinant DNA technology. To answer the question, done. Creatine mimetics, glycosylate. Let's do this. Okay, so I set the 8-minute timer. Let's go. Okay, 56-year-old male presents with a 5-week history of polyuria, polydipsia, and lethargy. So straight up, you can, could be type 2 diabetes mellitus, it could be type 1 diabetes potentially, and like to exclude diabetes insipidus. And he has a background of hypertension and high cholesterol. On examination, he's obese, he's old, so it's type 2, dry mucous membranes, heart rate, blood pressure. He's not hypertensive, and he is not febrile. What is my diagnosis? Given the patient's age and characteristic symptoms of polyuria, polydipsia, and lethargy, I'm concerned about type 2 diabetes mellitus. This could be potentially an exacerbation of his type 2 diabetes mellitus and possibly early progression to a hypoglycemic hyperosmolar state, given that he has some signs of dehydration with dry mucous membranes. Other differentials I would have would include causing polyuria could be diabetes insipidus, in which there is inadequate ADH causing increased diuresis, and this could be central nephrogenic. I'd also like to exclude other causes of polyuria. This could be urinary tract infection. Given he's male, benign prostatic hypertrophy can also progress to a polyuria. So what investigation would I like to get? I'd like to determine the chronicity, look for other symptoms of urinary tract infection, nocturia, difficulty opening their bladder, and potentially benign prostatic hypertrophy, and then past medical history. How long has this happened? Has this happened before? Any previous MIs? Any risk factors for type 2 diabetes? Difficulty with vision? Changes in volume of urination? So chest pain, any previous surgeries, and then family histories. Or a family history of type 2 diabetes, what medication he's taking, which could indicate he is diabetic, any allergies, and psychosocial history. How is he managing compliance? Is he seeing an endocrinologist? Is he looking at a foot specialist, potentially an ophthalmologist, to assess retinopathy, if this is diabetes? What investigations would I order? So my diagnostic investigation could include that of a HbA1c and also a fasting glucose, where values greater than 6.5% and 7 millimoles per liter are indicative of type 2 diabetes mellitus. I would like to begin with bedside investigations involving urinalysis, looking for any evidence of UTI. I might also like to do a urine microscopy and culture if there's an infective picture present. I could then do blood glucose level bedside as well, with a random blood glucose greater than 11.1, in addition to these clinical signs potentially indicating type 2 diabetes mellitus. I could then proceed to do a full blood count, EUCs, as the patient appears dehydrated, look at any evidence of renal impairment, and I could then do potentially a VBG if I suspect he's potentially acidotic, given, and this would be dependent on the blood glucose reading. And I could then do a random C-peptide to differentiate type 1 and type 2 diabetes, where C-peptide is a breakdown product of insulin, and the patient should have a normal C-peptide. And I could then do, and I'd probably seize there, and possibly, if I am concerned, if there's any chest pain, maybe an ECG, but at this stage, I'd likely not do any imaging. What are some lifestyle modifications? You can begin with diet and exercise. There's a dietary approaches to stop hypertension, because he is hypertensive, and he may also include physical activity, so approximately 30 minutes of physical activity 5 times a week would be ideal, and medical treatment. And then what is the medical treatment for diabetes? There are various medications for type 2 diabetes, and this includes medications that increase insulin sensitivity, medications that increase insulin release, and medications that decrease glucose absorption across the small intestines, and also increase glucose elimination from the renal tubules. Beginning with medications that increase insulin sensitivity, this includes your first-line therapies such as your biguanides, metformin. Metformin acts by increasing decreasing hepatic gluconeogenesis and increasing peripheral insulin sensitivity. Its side effects tends to cause potentially nausea, vomiting, GI disturbances. In rare cases, it can also cause a lactic acidosis, and it's contraindicated for patients who have hepatic or renal impairment, and notes is that it does not cause hypoglycemia, so it's relatively safe in that event. We also have your glitazones. These are PPAR agonists, typically PPAR gamma agonists, and they alter gene transcription and increase fatty acid translocation into adipocytes, thus increasing cellular reliance on carbohydrates such as glucose, and it decreases blood glucose in that manner. It also has similar effects to metformin in that it increases peripheral insulin sensitivity, decreases hepatic gluconeogenesis, and its side effects typically are weight gain and pedal edema. It can rarely cause weight gain and peripheral edema. It can also cause headaches. It's contraindicated in pregnancy. We also have your sulfonylureases. These bind and antagonize your ATP-sensitive potassium channels, preventing potassium efflux, and this can enable depolarization of the beta islet cells of the pancreas, resulting in calcium influx, release of insulin from insulin granules, and thus decreasing blood glucose. Side effects include it can cause hypoglycemia, and other side effects could include it can also cause weight gain as it can increase your appetite. It's contraindicated in pregnancy. We can also consider using GLP-1 agonists, so your incretin mimetics, and this includes compounds such as exenatide. And GLP-1 agonists, they increase GLP production in the duodenum and the proximal jejunum, and as a result we get increased insulin release, potentially can cause hyperglycemia, and side effects include it can also cause pancreatitis. And it's the same for DPP-4 inhibitors such as linagliptin. Your gliptins have a very similar effect. They prevent the breakdown of GLP-1 via the dipeptidyl DPP-4 inhibition breakdown pathway. So you get an increase in GLP-1 agonists, and it similarly can cause hypoglycemia and pancreatitis. You may not want to use these agents with sulfonylureases as they can worsen the hypoglycemia. And then we also have your SGLT2 inhibitors, and this includes your flozins such as dapagliflozin, and they work by increasing glucose reabsorption in the proximal convoluted they work by blocking proximal convoluted tubule sodium glucose cotransporters, and thus we get increased glucose in the urine, and via osmotic effect can also cause polyuria. And side effects can include can cause dehydration as there is an osmotic effect as mentioned. It can also potentially result in a urinary tract infection as there's now increased glucose content in your urine, and it may potentially cause hypovolemia and potentially even lactic acidosis secondary to that. Hypoglycemia, glycosuria, it can cause, let's not talk about lactic acidosis. What are your targets? You want it to be random glucose less than 10, HbA1c less than 7, and a fasting blood glucose between 4 and 8. In type 1 diabetes, use basal bolus regime as your short-acting insulin such as NovoRapid, acts in 15 minutes, and then basal insulin. What's your basal ones? Long-acting, there's glargine, insulin glargine. It's 1 case is that fat. Get the investigations right. Do fasting, random, HbA1c, OGTT, just do all of the glucose testing. And I didn't do lipid profile, I didn't do urine ketone. So we're suspicious of ketone, so you should also do a urine ketone. And then GFR, ECG, do a retinal exam. Look for the complications. So if I were to redo this, what investigations would you order for this patient? Since I'm suspecting type 2 diabetes, I might like to do my glucose investigations and urinalysis in the bedside. Urinalysis to exclude infections, glucose investigations including random blood glucose, potentially also fasting blood glucose. Eight hours. So then you're fasting blood glucose 8 hours. You can consider doing a HbA1c or a glucose tolerance test. And then we could also do a full blood count, EUCs, look at GFR, as I'm concerned about renal impairment, and also potentially ECG, rule out potentially there is a silent MI, as common among the diabetic population, and I like to also do assess peripheral vascular disease, do an ankle brachial index, and retinal examination, and although those are not investigations, I may also like to look at serum ketones, so VBG. Exclude a ketotic picture. Fatty acids repackaged. Friends of high glucagon forms keto acid. This keto acid falls through the glucon excess. So we could give food resource. Potassium. Dextrose. Investigations. Let's do this case of osteoporosis. So we consider musculoskeletal causes osteoporosis and other causes of decreased bone mineral density. The T-score is healthy and the Z-score is age-matched. Drugs, alcohol, age, medical conditions. Environment, drugs, alcohol, and medical conditions. Eyes, use drugs, alcohol, medical conditions again. Female postmenopausal Caucasian has medications, steroids, vitamin D, calcium intake, gait, vision, MSK. Gait, vision, MSK, hip.
Usually on one's first day is an orthopedic registrar, and certainly within the first week, one needs to know all about shortening, as it is so common and so important. I am aware that this does not apply as emphatically in other specialties. With regard to the methods of measuring for shortening, the most commonly described method is to measure the distance from However, I find the standing method using blocks has been more accurate. I use these blocks of 1/2 centimeter, 1.5 and 2 centimeters, so that one gets 1/2 centi increments up to 5 centimeters. It is also a 5 centimeter block. The next few slides will show how accurate this method is. Here is a person with equal leg lengths, and you can see the fingers placed on an iliac press are at the same level. In this slide, the right side has been raised on 1 centimeter and 2 centimeters. This is a very accurate anterior superior iliac shortening. If you look at example B, you can see that the left leg is shorter than the right. If you can then confirm that the pelvis is square and the legs are parallel, then you have what is called true shortening. If you look at example A, the diagram on the left shows an abduction contracture of the left hip, such that when the pelvis is square, the left leg crosses over the right leg. There is no way that the person can walk in this position, and the only way he or she can walk is to get the legs parallel, and the only way to do that is to hitch the pelvis up on the same left side. The person can now walk, and the legs are parallel, but the pelvis is not square. So the left leg appears to be short, even though
this person would have a apparent leg length discrepancy. There would not be a true leg length discrepancy, which tells you the issue is further up in the vertebra. Whereas if you have a true leg length discrepancy, then there is an issue with the actual joint.
No, it is not. This is what is termed apparent shortening.
Femoral acetabular joint.
Way to measure apparent shortening is to hitch his pelvis up on the right side to contract the affected leg. I have discussed a number of
commonly reveals an abducted. It's abducted and externally rotated with leg length discrepancy.
square and the legs are parallel, then we have what is called true shortening. If you look at example A, the diagram on the left shows the abduction contraction of the left hip.
True and apparent leg length, true leg length. Typically, this is current leg length. Current leg length is umbilicus to medial malleolus, and the discrepancy.
Such that when the pelvis is square, the left leg crosses out.
Original differentials. Osteoporosis could be primary or secondary. What's Paget's disease? Disorganized bone. Electrical fracture. So Paget's disease of bone is a disease of poor bone modeling. Increased bone disease of increased disorganized bone remodeling. So this weaker bone that is prone to pathological fractures and can lead to pathological fractures, deformities, largely asymptomatic, identified by increased fuzz and bone Okay. So osteomalacia, Page's disease of bone. I'd like to break down the causes of secondary osteoporosis into neoplastic. It could be a direct tumor of the bone, such as a chondrosarcoma or a multiple myeloma. It could be secondary, and that's where we consider our metastases to bone. It's your lead kettle, so your prostate, breast, kidney, thyroid, and lung. So cancers that metastasize to bone. This includes your PB, kettle, bosom, prostate, breast, kidney, thyroid, and lung. And also concerned about endocrine causes. There can be paraneoplastic effects of malignancies. There could also be Cushing's. So paraneoplastic, Cushing's, vitamin D, so renal failure, liver disease, first hydroxylation, and then it could be malabsorption. Okay, and then we can drug-induced, so thyroxine, corticosteroids can cause this. And then also ask what information, risk factors, osteoporosis, fractures, renal disease, investigations, you do a DEXA scan. Less than 2.5 and less than 2 indicates abnormal bone growth. Z scores if there's arthritis or crush fractures may not be required. 75-year-old with 2 independent risk factors, -1 to -2.5, less than -2.5. Just greater than -2.5 is osteoporosis. If the patient is less than 50 and we're concerned about a healthy adult. So in young patients, we may like to do T-score as a healthy young mean. May age match, so if we're suspicious of abnormal bone loss. If there's something other than aging contributing to bone loss. So even at a young age, what it should be. When would you look at a T-score? When would you look at a Z-score? The T-score is -2.5 standard deviations. The Z-score can be used if the patient is younger, and thus we're more concerned about factors other than aging causing, so we could tighten our controls, age and sex match controls. What else would you do? We could look at CMP, ALK-Phos, vitamin D, parathyroid hormone levels. What are the pharmacotherapies? There's your hormonal and anti-hormonal therapies. So there is your non-hormonal and hormonal therapies. Your hormonal therapies include your bisphosphonates, your rank ligand inhibitors. Let's go back to myself teaching. Go through osteoporosis. So in osteoporosis, we have our pathophysiology. Let's look at osteoporosis pathophysiology. Okay, so we have our osteoblasts. We have osteoclasts. And your osteoblasts can produce rank ligand. rank ligand, and that can bind to rank receptors. Rank receptors, and that will stimulate osteoclasts. Osteoclasts. Now we can also produce osteoprotegrin. Osteoprotegrin, go and block it. Can also produce osteoprotegrin. Inhibits rank ligand, and thus you increased osteoblast activity. And there is also, maybe do this in different color. Okay, and we can also use the osteoprotegrin, which is going to bind to and inhibit your rank ligand. And your rank ligand is your red molecule. These bind to these guys. And then it can also produce macrophage colony stimulating factor. That can stimulate macrophages. They can form more osteo. Macrophages. So we have macrophage colony stimulating factor as well. So that's what we have. So that's your pharmacotherapy for osteoporosis. How does teriparatide work? So intermittent use activates osteoblasts more than osteoclasts.
Blasts, which leads to an overall increase in bone. Teriparatide is sold by Uti.
What a disgusting presentation. So go to endocrine pharmacology, investigations, osteoporosis pathophysiology. We'll add this image. Oh, there it is. Wait. Okay, so the osteoblasts produce a couple of molecules, rank ligand, which binds to rank receptors and activates osteoclasts. Macrocyte colony stimulating factor will stimulate macrophages to then form osteoclasts. Okay, so the way all these medications work, let's understand this going back up to your different agents. So bind to hydroxyapatite crystals on bone, taken out by osteoclasts. Bisphosphonates are taken up by hydroxyapatite crystals, taken up by osteoclasts, inhibit signaling pathways for osteoclasts. Monoclonal antibody that binds to rank receptors. Raloxifene is a partial agonist of estrogen receptors, and it's an antagonist of breast and endometrium. So your parathyroid hormone. How does teriparatide work? Now we will have understood it. Teriparatide, the pulsatile release of results in a more pulsatile manner of parathyroid hormone release, which activates osteoblasts more than osteoclasts. One of the different ways of administering vitamin D can be IM, IV, subcut. It's preferred to be is cholecalciferol and ergocalciferol, D2, D3. D3 is more potent. Oral is preferred unless they have some GI bowel disorder. What are the benefits of hormone replacement therapy? It increases bone, reduces the symptoms such as flushing, vaginal atrophy, and then estrogen will increase osteoprotegrin levels, decrease MCS, and rank ligand production. And then that's how that works. Loxifene. Osteoporosis. There are genetic factors, physical activity, nutrition that causes a peak bone mass. The factors such as menopause result in increased expression of rank and rank ligand and osteoclast activity, and then aging itself decreases osteoblast function, and that predisposes to osteoporosis. Alright, let's answer this question. What are the treatment options, side effects? Bisphosphonates, I remember GORD, gastritis, osteonecrosis, eczema, denosumab, so my rank, eczema, hypercholesterolemia, MSK pain, osteonecrosis of the jaw. And your SERMs can cause signs of DVT, parathyroid hormone, HRT. Alright, I think I'm ready. GORD, esophagitis, gastritis, osteonecrosis of the jaw, eczema, hypercholesterolemia, SERMs cause flushing, parathyroid hormone can cause severe, it's not given bisphosphates, which does denosumab. Immune system. And ligand antibody. denosumab suppress the immune system? Doesn't. May cause immunosuppression. Okay, let's start osteoporosis. What's the time now? 12 minutes. Let's go. Okay, 81-year-old woman presents with a fall from shopping. She's got severe right pain in her right hip. Concerned about a fracture, MSK pathology. Could it be osteoporosis? I'm also concerned about Paget's disease of bone, osteomalacia. She's been admitted earlier in the year. She had a similar fracture after a similar fall. She was obese and the right leg was shortened and externally rotated. Vital signs. She's hypertensive and afebrile. Okay. So, given the repetitive fractures following a fall from standing height, I'm concerned about osteoporosis. The other differentials could include osteomalacia, which could occur secondary to the vitamin D deficiency. Also, in rarer cases, Paget's disease of bone, where adverse bone remodeling can cause pathological fractures. I'd like to exclude secondary causes of osteoporosis, but primary causes include age and postmenopausal status. Secondary factors can include potentially neoplasms of the bone, so a chondrosarcoma or a multiple myeloma can decrease and predispose to osteoporosis. Metastatic cancers from the prostate, breast, kidney, thyroid, and lung. I'd like to also exclude paraneoplastic effects of malignancies, and then other diseases, including endocrine disorders such as a hyperparathyroidism. Cushing's disease can also predispose to a weakened bone, and other medical conditions include liver and kidney disease. And then I'd like to also exclude pharmacological causes of osteoporosis, and this may include the use of glucocorticoids. And other differentials, MSK disorders such as muscular strain. However, given that the leg was short and externally rotated, I am concerned about a fracture. She's afebrile, so I'm not currently concerned about osteomyelitis, but I would like to rule this out as well. And she is hypertensive. What other information would I ask? I'd like to determine the nature of the fall, exclude my differentials, look at for risk factors for osteoporosis, old, postmenopausal, female, Caucasian, and then look for other risk factors for falls, so any drugs, age, any health conditions, medical conditions, and the surrounding environment. And treatment options. So the treatment options for osteoporosis include estrogen or hormonal therapies and non-hormonal therapies. Your non-hormonal therapies include bisphosphonates. The way bisphosphonates work is they bind to calcium hydroxyapatite crystals in the extracellular matrix of bone. They're then uptaken by osteoclasts and inhibit osteoclast activity and function. So we get a relative increase in osteoblast function and can thus decrease the decline in further bone density. Side effects of bisphosphonates include GI side effects. They can cause an esophagitis, gastritis, GORD, and rarer they can cause osteonecrosis of the jaw, which is a concern. We also have your antibody therapies such as denosumab. This involves a 6-monthly injection. It is a monoclonal antibody to RANK ligand. So So denosumab binds to rank ligand and inhibits its binding to the rank receptors in osteoclasts. This decreases osteoclast activity. And side effects of denosumab, it's known potentially to suppress the immune system, and it can also cause eczema, hypercholesterolemia, and joint problems. Then we also have our hormonal therapies, and this includes your selective estrogen receptor modulators such as raloxifene. They work by acting as an estrogen agonist in bone and an antagonist in the breast and endometrium, so they don't confer an increased cancer risk. However, they increase the activity of increase estrogen-like effects on bone. This includes increased osteoprotegrin levels, decreased rank ligand, and decreased macrophage colony-stimulating factor secretion by osteoblasts. Side effects of our raloxifene include typical symptoms of a hyperestrogenic state. So you can cause They can cause flushing, headaches, potentially atrophy of the genital tissue, and we also have your parathyroid hormone analogs such as teriparatide. The way they work is it's a daily injection that's subcut, and this results in a more pulsatile secretion of a parathyroid hormone analog, which relatively activates osteoblasts more than osteoclasts. However, this is reserved for severe bone disease. And the benefits of hormone replacement therapy in this woman is hormone replacement therapy is another option, and the benefits of hormone replacement therapy for this woman include increased osteoprotegrin secretion, decreased macrophage colony stimulating factor, and decreased rank ligand released by osteoblasts, which will accumulate in decreased osteoclast activity and increased bone density. And however, I would be concerned in this woman particularly because she's 81 and there is an increased risk of cardiovascular disease in patients of this age cohort, so I may not consider it here. The pathophysiology of osteoporosis is due to an imbalance in which we have excess osteoclast activity relative to osteoblasts. Individuals typically start off with their peak bone mineral density in their 20s, and this is controlled by genetics, diet, calcium supplementation, and weight-bearing exercise. Then we see a steady plateau of the bone mineral density, and this can occur secondary to postmenopausal states, which can increase osteoclast activity, and then age, which can decrease osteoblast activity as well. And this culminates in an increase in rank ligand, a decrease in osteoprotegrin, increase in macrophage colony stimulating factor activity, which culminates in decreased bone mineral density. And we can identify this via a dual X-ray absorptiometry or a DEXA scan. And a DEXA scan can measure the T and Z scores, where a T score is the bone mineral density matched to a healthy general population, and a Z score is age and sex matched to the individual, and a T score less than 2.5 or greater than 2.5 standard deviations from the mean is indicative of osteoporosis, and 1 to 2.5 standard deviations is osteopenia. Done all my endocrine farm. Graves, have a quick look at Graves again, understand that. What else do I need to know? What are the different pharmacotherapies? Well, we said for osteoporosis it's your non-hormonal bisphosphonates, denosumab, and then your hormonal, which is your SERMs, your teriparatide, and your hormone replacement therapy. It's the main things, right? So then we can consider Graves' disease. Quickly go through that. What's the time? 4 minutes. Go through Graves in 4 minutes, and then I'll take my break. Let's see. 35-year-old woman presents with symptoms of hypothyroidism. Blood test results reveal a high T3, T4 and a low TSH. High T3, T4 and a low TSH, which is hypothyroidism, typical. And what is my diagnosis? It's that of hypothyroidism. The main causes of hypothyroidism include Graves' disease, the acute phase of Hashimoto's, subacute thyroiditis. Subacute thyroiditis, and this could include, for example, Raydel's thyroiditis. Dequervain's is the hypothyroid, and then it results in a euthyroid state. Hypo, U, and then also. Okay, so my diagnosis, given the patient has hypothyroidism, is number one. My primary diagnosis, provisional, would be that of Graves' disease. I'd like to exclude subacute thyroiditis, toxic multinodular goiter, and acute phase of Hashimoto's disease. And I could exclude, is there anything else? Subacute is Dequervain's. And then non-thyroid sources, I remember this, levothyroxine, amiodarone, diet, and metastatic follicular carcinoma, I'd like to exclude. And then thyroid secretion. So ovarian teratomas, other paraneoplastic effects of other cancers such as teratomas, diet, and it can be a subacute such as Dequervain's, postpartum, and thyrotoxicosis, given the patient's age and gender. Middle-aged female, you consider Graves, and thyrotoxicosis, state of thyroid hormone excess. This is thyrotoxicosis secondary to likely Graves, given the patient's age and gender. I'd like to exclude Hashimoto's, toxic multinodular goiter, and a subacute thyroiditis. That makes sense. And if I'm concerned about a neck lump, what would I say? I'd say Graves, Hashimoto's, and then I'd say it could be a thyroid adenoma, carcinoma, congenital or thyroglossal cyst, and then benign, which could include a physiological goiter, toxic multinodular goiter, thyroid cyst, and then non-thyroid causes, craniopharyngoma in older population, lipomas, lymphomas, abscess. So causes of a neck lump include Graves' disease, Hashimoto's, malignancy such as thyroid carcinoma or an adenoma, and then inflammatory causes such as subacute toxic multinodular goiter, thyroid cyst, and congenital thyroglossal duct cyst, and then dermoid, epidermal, lipoma, lymphoma, and then lateral neck lump, lipoma, abscess, carotid aneurysms, lymphangiomas, and then a pharyngeal pouch, branchial cyst. Right, what investigations would I perform? You do thyroid function tests. You could also do, what would the key differences be? I'd do a thyroid function test. Bedside, I wouldn't change anything. I'd do a thyroid function test. I would do, given that I'm concerned about Graves, I'd be looking at anti-TSH antibodies. I'd like to maybe slap on thyroid peroxidase antibodies, since it's Hashimoto's is a differential, and then find your last period ultrasound, right? TFTs and then an ECG, given that's tachycardia. Anti-TSH receptor antibodies, ultrasound, and then technetium radionucleotide scan. I could consider an MRI brain. So the investigations you perform is your typical thyroid function tests, but you would add on, since we're concerned about Graves, anti-thyroid stimulating hormone antibodies. Also like to do a funded last period ultrasound, and I could consider doing a technetium-99 radionuclide scan, and then if it's a central cause, do an MRI as well. Does hypothyroid explain the patient's symptoms? What symptoms do they have? It alters, thyroid hormone acts on receptors, increases gene expression. With beta adrenergic receptors, the sodium potassium ATPase pump, and that increases heat production. Basal metabolic rate, body temperature, due to increased activity of sodium potassium ATPase. Acts on all tissues except the brain, gonads, and spleen. They increase in metabolism due to increased cytochrome oxidase and increased respiration enzymes, such as cytochrome oxidase, alpha glycerophosphate dehydrogenase, and this can potentiate. This results in sodium potassium ATPase pump. We also increase metabolism due to increased cytochrome oxidase, increased enzymes that can overall result in increased proteolysis, lipolysis, and gluconeogenesis, increased cardiac output due to increased beta-1 receptors, and there's also more synthesis of cardiac myosin, and there's also a synergistic effect increasing growth hormone, and there is also CNS effects. There's more neurogenesis. That's what thyroid hormone is important for. That's why it causes decreased memory. You can get a hyperexcitability, hyperreflexia, and then reproductive hypothyroidism, more sex hormone binding globulin. It binds for estrogen and testosterone. So in women, get amenorrhea, oligomenorrhea, gynecomastia. There's increased sodium potassium ATPase production, increased beta-1 receptors that cause increased cardiac output. There is increased activity of cytochrome oxidase and other enzymes that increases lipolysis, proteolysis, gluconeogenesis. There is a synergistic effect with growth hormone. There is CNS neurogenesis, and there's reproductive effects. Holy smokes. And the clinical presentation is general, breakdown by organs. You can have exophthalmos to the deposition of connective tissue, inflammation. You can get lid lag, sympathetic system, sinus tachycardia, AF, respiratory. They can have dyspnea due to increased oxygen utilization, and this is secondary to increased activity of the sodium potassium ATPase pumps. We increase beta receptor production, GI, and this can be to increase catecholamine release, and CNS reproductive. And how does it cause hypertension and tachycardia apart from sympathetic activation? Hypothyroidism causes, apart from sympathetic overactivation, it can cause tachycardia and hypertension through potassium ATPase pump, increased beta-1, catecholamine release. There's also beta-1 expression. Myosin filaments that increase stroke volume. It also acts on peripheral increased receptors. Look at the RAS system. Use inotropic chronotropy. Holy shit. Beta-1 receptors that increase cardiac output, but then T3, T4 can cause vasodilation, activate the RAS system, decrease in mean arterial pressure, renal perfusion, increase renin release from the juxtaglomerular cell of the afferent arteriole. It gets used up by liver. The renin will break down angiotensinogen from the liver, produce angiotensin 1 that's converted via ACE, angiotensin converting enzyme, and into angiotensin 2, and it's going to increase inotropy and chronotropy. Effects of aldosterone, direct vasoconstriction, activation of the sympathetic nervous system, and just recap where does ACE come from? It's for pulmonary epithelia. ACE comes from lungs. This comes from the lungs. And capillary blood vessels in the lungs, ACE expression. Yeah, it's capillary blood vessels in the lungs. activates the sympathetic nervous system, right? First, kidney juxtaglomerular cells, angiotensin 2, RAS, blood volumes, once the hypothalamus, antidiuretic hormone, and it causes vasoconstriction. Yeah. So we have vasodilation, and then, however, so how does hypothyroidism cause hypertension apart from sympathetic overactivation? So beta-1 receptors can increase cardiac output, which can increase your blood pressure, and can also cause chronotropic effects. But we also have T3, T4 can act on blood vessels, cause vasodilation, decrease renal perfusion, activate RAS, and the activation of the renin-angiotensin-aldosterone system will result in increased sympathetic outflow and thus increase cardiac output. It's a drug vasoconstrictor as well, so it's going to increase blood pressure. What is a thyroid storm? It's acute life-threatening thyrotoxicosis. Maybe secondary to surgery, trauma, infection, usually febrile, in hypovolemic shock. They can have tachyarrhythmias, hypertension, coma. The treatment is propylthiouracil, dexamethasone, and you can use propranolol to control tachycardia, dexamethasone to prevent conversion of T4 to T3, Lugol's iodine, which is thyroid hormone release, Lugol solution, and you can also have propylthiouracil in hypothyroidism. As a treatment for hypothyroidism, we use thionamides. They inhibit thyroid peroxidase, and their side effects include rash, urticarias, peroxidase, rash, urticaria, fever, arthralgia, rufa. Rash, urticaria, fever, arthralgia. Hepatitis, this includes propylthiouracil, cause of cholestatic hepatitis, agranulocytosis, and SLE-like disease. Is carbimazole. First-line drug, it's contraindicated in breastfeeding. Propylthiouracil, hepatotoxic, will cause rash, urticaria, fever, arthralgia, rufa. Rash, urticaria, fever, arthralgia. So your thionamides and propylthiouracil can cause cholestasis, SLE, agranulocytosis, and we can use beta blockers and radioiodide ablation, thyroidectomy. Going through, how do you calculate the anion gap? It's chloride. It's sodium plus potassium minus chloride and bicarb. Reference range, there's increased anion gap seen in metabolic acidosis. It tells you they're unmeasured. Metabolic acidosis are unmeasured ions. With the anion gap, and rash, urticaria, fever, arthralgia, side effects, rarer, Nitidus cholestasis, agranulocytosis, urocytosis, and carbimazole. Well, is first line. It's contraindicated in pregnancy. Radioiodide ablation, ketoacidosis, relative excess of glucagon. Glucagon also results in increased use of precursors like acetyl-CoA to form your ketones. Three features: increased ketones, increased glucose. There's increased ketones as first of all we have a relative excess of glucagon versus insulin, and that results in increased glycogenolysis, increased gluconeogenesis, and we can get dehydration. It's glucose, sends ketones, there's metabolic acidosis, there's the ketoacids react with bicarb. Polyuria, so urine more than 3 liters per day. Polydipsia is increased thirst. Symptoms and signs: you get abdominal pain, precipitates infection. How do you calculate iron gap? Measure the pH, general practice, tube function, interpreting blood gas. 7.35 to 7.45, 35 to 45, 80 to 100. 20 to 26, -2 to +2, and then metabolic alkalosis, base excess. There is, it's increased base excess. Kussmaul type, anion gap, keto, lactic, ethylene glycol, paracetamol, and then it could be normal ion gap. There's no additional acids, so it's probably due to a diarrhea, interstitial nephritis, renotubular acidosis. There's no new acid being made, so renotubular acidosis, interstitial nephritis. What does a base excess tell you? Base excess. Metabolic disturbance. Dose of acid to return it to normal pH. Bases. See, it's hypochloremia, GI losses, normal base excesses. How does that make any sense? I'm confused. I'll stop and taking a break. I'll take it after this. carbonate base excess is the amount of acid to return the blood. So if it's negative, so there is excess acid. Positive, that makes sense. Which is 7.4. And normal base excess means there is abnormal anion gap. It's dealkalosis. That's just fancy stuff. Anion gap is what we need to interstitial nephritis. It could be GI losses, renal tubular acidosis, acetazole, hypochloremia, interstitial nephritis, GI losses, and then normal base excess, lactic acidosis. Yeah, alright. Renal tubular acidosis, acetazolamide. Okay. Normal ion gap seen if bicarb has just been lost as an excess acid. Ion gap. There are unmeasured anions A minus coming from external acid. And if it's a normal anion gap, there. Unmeasured anion or that makes sense. Normal iron gap, increased iron gap. Let's see, renal tubular acidosis. Spironolactone is a potassium-sparing diuretic. It increases potassium in the distal convoluted tubule, and in the distal convoluted tubule, and that will exchange via the potassium hydrogen exchanger, and that can cause an alkalosis. Why does it cause an acidosis? Who knows? Metabolic acidosis. Why does that happen? Oh wait, let's see. Spironolactone blocks aldosterone, so there's going to be less potassium, and in the collecting duct there's going to be less hydrogen potassium exchange, so causing metabolic acidosis. That makes sense. Okay, 5-minute break. take a break. See y'all in 15 minutes. juice module. So, center middle branch gels posteriorly. Septal branches. Clatter. And strain the cardiac sides. Posterior cardiac vein from the apex and drains into the coronary sinus. It's from the anterior interventricle, septa, focus, sinus, then drains into the right atrium. The Bayesian veins. Of the diaphragm, blood supply. So if your left gastric artery is a curvature, splenic artery goes to the spleen, is a short gastric, and your left gastric oblique, and then is your common hepatic, which then gives off your gastroduodenal, is your gastric oblique, and superior pancreatic duodenal, and then your hepatic artery proper. Signal lymph nodes. Pancreas is going to be your splenic artery, your pancreatic duodenal artery. Venous is the same, and your pancreatic is splenic pyloric lymph node. Celiac nodes to the system, left lymphatic or thoracic duct. Bowel duct, cystic artery, and your right hepatic artery. Cystic artery, right hepatic artery. And your celiac nodes. Celiac, and your cystic artery. Arteries branch of the internal pupil. Branch of the internal iliac artery. Symptomatic greater than 5.5, and there are emboli. Prosthetic graft or a stent. You're replacing your graft, you can use an endovascular stent. So again, pancreas is your superior inferior pancreatic duodenal arteries, your splenic arteries, it's your celiac, your gastric, and your celiac pyloric, and your celiac nodes. Your pancreatic or splenic pyloric nodes go into celiac nodes, and celiac nodes, right hepatic, and your common hepatic duct, and your cystic duct, bowel duct, cystic artery, right hepatic artery. Cardiophrenic, musculophrenic, angiophrenic, parasteric nodes. Such as rheumatic heart disease, myocardial infarction, pericarditis. Liebman stacks, endocarditis, non-bacterial, thrombotic, PE. Yeah, I can go through all of that, that's fine. You ask him history and exam. From Jane, signs and symptoms, fevers, red spots. Also nodes. Murmur. I'm full. Anemia. No, but hemorrhages. Blood cultures. 3 blood cultures. Trepidians bovis. Endocardial involvement. Vegetation, mass, abscess, breakdown of the valve. And criteria of risk factors, vascular and immunological phenomena. Also, nodes are painful and immunological. Rot spots. Arterial emboli, conjunctival hemorrhages, pulmonary narcotic aneurysms, intracranial bleed, arterial emboli, two major, and one major, 3 minor, 5 minor, 2 major, 1 major, 3 minor, 5 minor. Major criteria of blood cultures, and then evidence of endocardial involvement. Then minor criteria involve risk factors, previous rheumatic fever, drug use, congenital heart disease, and then immunovascular phenomena. So Janeway lesions, narcotic aneurysms, hemorrhages, pulmonary aneurysms, pulmonary emboli. Nephritis, also nodes, rot spots, and then premature factor. X-ray. See increased calcifications and evidence of pulmonary congestion. If there is see evidence of heart failure secondary to valve problems. We get a bit of mitral regurg and see evidence of pulmonary congestion. Mitral regurg. So you can see Janeway lesions, myocardic aneurysms, emboli, so it could be intracranial bleeds, secondary to septic emboli, pulmonary emboli, renal infarcts, myocardic aneurysms, immunological, you can see glomerulonephritis, ulcers, nodes, so much. But we add on ulcer nodes, red spots, rheumatoid factor. And then you think of myocardic aneurysms, Janeway lesions, and then emboli. So all your different emboli, hemorrhage, Janeway lesions, myocardic aneurysms. So vascular phenomena. You think of your Janeway lesions, think of your splinter hemorrhages, and then you think of your cardiac aneurysms, think of your intracranial bleeds, then you can embolization. Lungs, kidney, where else? What's the main thing? Right. So you think of your Janeway lesions, hemorrhages, myocardic aneurysms. What do I expect to see on chest X-ray? Evidence of a valve involvement and that could cause concurrent heart failure. What are the organisms most likely to be affected? So there is your Streptococcus viridans, which is the most common overall, low virulence, has to damage existing valves, Strep bovis associated with colorectal cancer and UC, and then the Staphylococcus aureus, high virulence, and then Staph epidermidis, which is most commonly seen in prosthetic valves. And there's Enterococcus, and there's your Ascec group of organisms, Haemophilus, Agrigotobacter, Cardiobacterium, Aikenella, Kingella, Haemophilus, Agrigotobacter, Cardiobacterium, Keonis, Coxiella burnetii, can also cause it. Associated with initially Q fever and then infective endocarditis. The pathophysiology of infective endocarditis. Bacteria can injure the endocardium, causes platelet and fibrin due to the damaged site, and there can be bacterial proliferation fibrin, you can form aggressive vegetations. Injure the endocardium, bacterial injury to endocardium, fibrin, platelets, proliferates, and neutrophils, can cause proteases in the vegetable that are able to embolize, and there is endothelial injury, and there are sterile vegetations that can be colonized. Urine vegetation. The prevalence factors, coagulase, can prevent clot formation, phagocytosis, hyaluronidase, there's deoxyribonuclease, lipases, staphylokinase, coagulase, and staphylokinase dissolves fibrin, and coagulase can clot plasma, avoid phagocytosis, splenectomies. So what are the virulence factors of Staphylococcus aureus? It has coagulase, which can form thrombi in plasma, and also evade phagocytosis. There's staphylokinase, which breaks down fibrin clots. There's your deoxyribonuclease, which breaks down DNA in cells. There's lipases, and there's other toxins. How would you treat this? Uncomplicated is 4 weeks of management. Gent, Fluclox, and Benpen. Gent, Fluclox, and Benpen. And then you do Gent and Fluclox and Vanc as a prosthetic valve. So Gent, Fluclox, and Benpen. It's a native valve. There's Gent, there's Benpen. So gentamicin covers the gram-negative organisms. So we said it was one of the causative organisms. Staphylococci, Strepto, Enterococci, and then your HACCP group of negative organisms. So Gent for the negative organisms, HACCP group. So how would you treat this? The logic is rationale that we have Benpen for staph, strep, Radians, bovis, and then gentamicin for the HACCP gram-negatives, and then we have Fluclox, so then just as an add-on. Switch to Vanc. Switch to vancomycin. If prosthetic. Right, and then what most likely occurred? He's got dyspnea, emboli, pulmonary arteries, and that can cause infarction. It's dyspnea and a pleuritic chest pain, emboli, flushing pulmonary artery. But more complications, you can get cardiac, you can get valvular abscess, you can get destruction of the conductive system, arrhythmias, you can get myocardial fistulas, you can get a suppurative pericarditis, you can have emboli, cause infarction and abscess, you can get glomerulonephritis, renal failure, and then other emboli can cause abscesses deep in the body and sepsis. There are various complications of infective endocarditis. We can have complications including direct damage to the myocardium, which could include formation of abscesses, myocardial fistulas, damage to the electrical conductive system causing arrhythmias, and then we can also have effects due to embolization, so we can have pulmonary emboli, renal emboli, you can get a stroke due to septic emboli to the brain, and that can and we can also get myocardic aneurysms, vessels due to deposition of the emboli. And then we can also get abscesses deep in the body, and then immunological phenomena. You can think of is glomerulonephritis, pericardic. Break it into cardiac, vascular, and immunological processes. Right, so your vascular processes can include your valve, conductor system, myocardium. You get myocardic aneurysms and arteries. You get infection of the myocardial wall. Myocardic aneurysms of the myocardium. Arteries, you can get infection of the arteries and myocardic aneurysms. You get a suppurative pericarditis. You get a stroke, hemorrhage or abscess, infarction or abscess, glomerulonephritis, renal failure, metastatic infection, sepsis as well. Compare community acquired to hospital acquired. So feature community to hospital acquired MRSA. So it's usually seen in ICU patients, IV lines, patients that are immunocompromised, IV drug users, smokers. You see it in prisoners, children, beta-lactam resistance. Yes, multi-drug resistance is common. It's beta-lactam resistance. So what you're trying with the pen. Sulfamethoxazole. UVL toxin. Staphylococcus. Antoine Valentine, leukocidin, cytotoxin. Staphylococcus aureus. Bloodstream. Some infections. Can't really say much there. So cardiovascular diagnostics, path, myocardial infarct. What's your diagnosis? MI and STEMI. And then differentials, cardiac, respiratory, psychiatric. Yeah, we've got all of that. What investigations would you perform? ECG, cardiac biomarkers, coag string, because you're going to put them on heparin, CTPA, what are risk factors for MI to quantify the risk. You looked at absolute cardiovascular risk guidelines, and is modifiable, non-modifiable. It's all fine. And then the complications of myocardial infarct. So within hours, electrical abnormalities, predisposed to arrhythmias. Within days, you see cariolysis, when nucleus fades, pycnosis, and choriorexis. Think of a little T-Rex rush. Pycnosis, choriorexis within days. And in 1 to 3 days, you may see fibrinous pericarditis due to neutrophil infiltration. There's a mottled appearance. 3 to 7 days, it becomes darker. Phagocyte recruitment, and there's a chance of rupture. 1 week, there's a tan appearance due to granulation tissue and more of a red appearance due to angiogenesis. And then 1 month, you have a white collagen scar. And this is where you have a weakened myocardium, so you can form a mural thrombus, aneurysms, and Dressler's. It can happen in the months phase, so hours. So again, what are the pathological findings and complications? Within hours, we start to see some of the sodium, potassium, ATPase pumps, electrolyte derangements in the myocardium, and that can predispose to arrhythmias. Within hours to days, we begin seeing neutrophil influx, And we start to see nuclear changes within hours, such as chirorrhexis, nuclear fragmentation, karyolysis where the nucleus fades, and pyknosis where there is condensation of the nucleus. Within 1 to 3 days, we observe a pale appearance of myocardium. We see neutrophil influx, it's a pale mottled appearance, and this can increase your risk of fibrinous pericarditis. Within 3 to 7 days, this phagocyte recruitment becomes darker, and it's prone to rupture in the ventricular free wall, the ventricular septum, and the posterior medial leaflet of the mitral valve, that can cause a mitral regurg. And then in 1 week, we can observe a more tan red appearance, and this is due to increased fibroblast angiogenesis occurring, and then a collagenous scar tissue at a month, which can indicate that there is Dressler's aneurysms can occur in this time period. What disease process underlies this condition? Why did they get a emboli? And it's due to myrothrombus, right? With atherosclerosis, thickening of the intima, erotic lesions, cholesterol. Large vessels, and then effects on small vessels, and as you can break this down via the heart. In the heart, we may observe that there is concentric hypertrophy. Diastolic heart failure. Ejection fraction. Systolic and systolic FF. With reduced ejection fraction. Preserved ejection fraction. Very stiff myocardium. FF. It can cause impaired feeling, and that results in diastolic heart failure. So the key point was that ejection fraction is a percentage that actually gets pumped out. The diastolic issue of the heart's too stiff. Stiff heart. Anyway, we can also get large vessels, large, medium vessels, and this is where we can observe large shear force can cause increased risk of aortic dissection. We may also observe evidence effects on medium-sized vessels, and for medium-sized vessels we may observe in a medium-sized vessel there is damage to the large vessels. Effect on medium vessels includes atherosclerosis. Right. And then we can refer to the complications of atherosclerosis. And complications can include, you can get myocardial infarct, stroke, peripheral vascular disease, and then you can refer to what happens in small vessels. And in small vessels, we can have, in our small vessels, we can have small vessels, we can have intimal fibrosis, and then we can have our higher line arteriosclerosis. Higher line arteriosclerosis. And the higher line arteriosclerosis causes two things. Narrowed lumen, which can cause ischemia, and end organ dysfunction. So we can see that with hypertensive retinopathy, hypertensive nephrosclerosis, which can cause chronic kidney disease. And then we can have weakening of the wall. And that can predispose to, weakening of the wall can predispose to, rupture. So we can get lacunar infarcts in the brain. So I guess all the complications are listed here. So the effects of hypertension include effects on, so you can get concentric hypertrophy, you can get heart failure, you can get dissection, you can get atherosclerosis, MI, stroke, PVD, we can get lacunar infarcts in the brain, we can get ischemia and end organ dysfunction, hypertensive retinopathy, hypertensive nephrosclerosis, which can progress to chronic kidney disease. So that's the effects of hypertension on the body. Neovascular. Pharmacology. Pathology. Diagnostics. Let's go hypertension. What are the mechanisms of hypertension? Renin-angiotensin, aldosterone, autonomic nervous system is vascular mechanisms. So hypertension drugs, lipid metabolism. Anyway, going back to this, what's the mechanism here? Atherosclerosis. Fibrous cap. So, what process is atherosclerosis? And this is associated with the deposition of cholesterol and cholesterol esters into the thickening of the intima and deposition of cholesterol esters into the endothelium. So, and this causes the influx of foam cells, macrophages, to the site of injury. And so atherosclerotic plaque formation occurs in high shear stress. There's a carotid, cerebral arteries, and it contains a fibrous cap, smooth muscle cells, mobility, LDL, containing lipid-laden foam cells. So, atherosclerosis is a chronic inflammatory process characterized by the deposition of cholesterol and cholesterol esters inside the endothelium. This causes the influx of macrophages due to the inflammatory response that will consume the cholesterol and form foam cells. They will also then release cytokines that causes the deposition of smooth muscle. That results in the deposition of smooth muscle and formation of a fibrous cap, which causes intimal irreversible, all this stuff. So I wrote something about this. Med students is atherosclerotic plaque. Foam cells trigger production of formation of extracellular matrix. Cardiovascular disease. Pathophysiology, chronic stress, endothelial dysfunction, reduced invasion of inflammatory cells, and formation of the vessel wall, dangerous to cholesterol, and they transform to foam cells, and they form fatty streaks, and then they produce extracellular matrix that results in a fibrous atheroma. And there's inflammatory cells such as macrophages and matrix metalloproteases, which will eventually weaken that fibrous cap of the plaque, and this can result in a rupture and occlusion. That's the pathogenesis. It's a way better pathogenesis than this bullshit long answer. So there is chronic stress. So endothelial injury can result in the deposition of cholesterol and cholesterol esters, and this can result in an inflammatory process that results in the migration of macrophages, which will consume, oxidize the cholesterol, and form foam cells. And at this point we can observe the atherosclerosis as a fatty streak. These macrophages will then release cytokines that causes increase in collagen production, the formation of a fibrous cap, and formation of an atheroma. They'll also release proteases such as matrix metalloproteases, and this results in breakdown of that extracellular image matrix. In order of increasing frequency, common sites, circle of Willis, dumb aorta. What are the common sites of cardiac rupture? Pili muscle, OV septum, tricular free wall, dextride, hypertension, JVP, muffled heart sounds, describe the specimen above, cardiomyocardial, so wedge-shaped infarct, mural thrombosis, and this can result in embolization of a mural thrombus, so wedge-shaped infarct. Pathological findings. Infarct, kidneys, beard, nephropathy, lacunar infarcts, lenticular striate arteries, Charcot-Bouchard aneurysms, DVT, splenic infarcts. Basal ganglia, thalamus, hypertensive hemorrhages. Right. Rupture. The formation of Charcot-Bouchard aneurysms. Lacunar infarcts, weakening of the wall. We can get formation. We can get aneurysms. Aneurysms. Call it Charcot-Bouchard aneurysms. Aneurysms. Okay, aortic dissection. What are my differentials? What investigations would I order? Well, for a dissection, it's a CT. It's a contrast CT looking for an intimal flap. That's it, CT. For a flap, you can see broad widening of the mediastinum and bedside ECG, ventricular hypertrophy, PE, do a toe, sure. So these investigations, why the normal troponins, elevated creatinine. Patient presented aortic dissection, retrosternal pain radiating towards the back. Is a weak radial artery pulse, which tells you that the dissection is likely type A, and it's likely between the brachiocephalic trunk and the brachiocephalic trunk and the left subclavian. Or it could be proximal. Chronic hypertension, pancreatitis, perforated peptic ulcer, CG, explain the findings, renal findings. Why is there increased GFR? There's renal kidney injury, there's diastolic murmur, because the aortic valve can often be damaged in a dissection. It can lead to aortic regurg, and there's a wide pulse pressure, bounded pulses, and some cardiac failure. Right, look at the pathological specimen. How does this occur? I have no clue. This is a myocardium that appears to be dilation prior to normal aorta, and it appears to be that there is tear in the intima. Blood dissects into the media, showing false lumen, and this can include flow through true lumen. Marfan's, Ehlers-Danlos, hypertension. Remaining can be due to inflammatory conditions, trauma, and then there's type A, type B, sudden tearing chest pain, even widening in the pulse pressure, narrowing of the pulse pressure, right? Wide pulse pressure. What does that mean? The diastolic is very low. It makes sense secondary to regurg. Yep. Other risk factors: mention age, hypertension, cocaine, Marfan's, Ehlers-Danlos. How do you manage this? Type A is urgent surgical repair. Type B is acute medical therapy. So type A is urgent surgical repair, type B is acute medical therapy, and you can use beta blockers, you can use sodium nitroprusside, that's a vasodilator, cholesterol trinitrate, and yeah, you could, if it's complicated, you could do surgical repair. How do you manage it? So type A is coronary occlusion, aortic regurg, loss of arm pulse, and that's if you have dissection. Yeah, dissection distally. Type B, renal or mesenteric occlusion, blood pulse. Marfan's due to a mutation fibrillin 1. That causes skeletal changes, long thin bones, reduced vision, dislocation of the lens, cardiac problems. So we can just put anatomy, we can put it to, and the diagnostics, we can put it to. Path with myocardial infarct and dissection. It's not too bad, but pharmacology is what I should put my too advanced. And then neuro. Okay. What are the guidelines? What are the mechanisms of hypertension? Physical activity dash. Use varenicline, bupropion. Smoking. Dopamine or adrenaline reuptake inhibitor. It's a partial agonist of nicotinic receptors. So it can antagonize nicotinic receptors in the presence of nicotine itself. And it's a partial agonist. So both are partial agonists, but it's also a dopamine or adrenaline reuptake inhibitor. So, yeah, whatever. Partial agonist. What are the mechanisms of hypertension? Through activation of the renin-angiotensin-aldosterone system. It can result in potent vasoconstriction. It can be increased beta-1 activity that can increase heart rate. There can be decreased beta-2 activity. Mechanisms of hypertension can be broken down using the formulas where blood pressure is equal to cardiac output times total peripheral resistance. So vasoconstriction can result in increased total peripheral resistance. It can increase heart rate. Similarly, increased heart rate conditions, stroke volume conditions, that can cause sympathetic outflow, the RAS system. The vascular radius itself. If there is arteriosclerosis, the vascular radius itself can decrease. So to sum things up, hypertension occurs due to increased RAS activation, poor perfusion. It can occur due to increased sympathetic activity, and it can also occur due to decreased compliance of vessels due to intimal fibrosis and cardiac. What are the blood pressure targets? Less than 130 if there's associated endorphin damage. Basically, the formula for base excess. Base excess is the amount of acid or base required to return the pH of blood back to 7.4. So if the base excess is negative, there's not an excess of base, there is a deficiency of base. So that just explains that it could be a metabolic acidosis. Where it's high, it just means it's a metabolic alkalosis. There is a base excess. So nothing interesting there. Anion gap is solely just chloride plus, so it's your cations, which is sodium plus potassium minus chloride plus bicarb. And if it's raised, that tells you there is some other anion, which is from an acid in the blood. So there's some unaccounted acid, and that could be lactic acidosis, it could be aspirin use, it could be ketoacidosis, for example. Whereas if the anion gap is normal, it means it's just low bicarb, there's no extra acid. Low bicarb can happen due to vomiting states, it can happen due to drugs like acetazolamide, and it can happen due to renal conditions like interstitial nephritis. Holy smokes. Holy can use an ACE or an ARB and a calcium channel blocker. So first line is using an ACE or an ARB or a calcium channel blocker or a thiazide diuretic, and then you could consider an ACE ARB and a calcium channel blocker, an ACE ARB and a thiazide diuretic, and then you could consider potentially thiazide, and then you don't want to consider beta blockers, and beta blockers are not really first line at all, in fact. Okay. So what are the mechanism of actions of these hypertensive drugs? Lip diuretics inhibit the sodium potassium T-chloride cotransporter. Yeah, that looks pretty cool. I might put it on there. Sodium potassium T-chloride cotransport and the pigmentating it can cause hypokalemia, hypochloremia. It can cause metabolic alkalosis, as now there's more potassium exchanges with the hydrogen, and side effects can include metabolic alkalosis, also impact glucose control, increase your risk of gout, and thiazide diuretics inhibit sodium chloride cotransporter, prevent reabsorption of sodium, and that it's not thiazide diuretics not indicated in individuals less than 65 can cause hypoglycemia risk. Right, and it can cause hypokalemia. Why can it cause hypokalemia? Because there's increased activation of the aldosterone, sodium reabsorption, potassium secretion, and it causes hypokalemia, hyponatremia, and it causes hypoglycemia, uric acid retention. Potassium-sparing diuretics such as spironolactone can cause a hyperkalemia, and it can cause a metabolic alkalosis, as now there's more potassium. Now there's less potassium, less hydrogen exchange, because of metabolic acidosis too. And ACE inhibitors they inhibit ACE, which prevent the action and formation of angiotensin II. It can cause a cough, angioedema. It can cause hyperkalemia, as we're inhibiting aldosterone activity, which reabsorbs sodium, secretes potassium. So by blocking your aldosterone, you can get a hyperkalemia, cough, angioedema. It can cause a hypotension. And it's the same side effects, except you don't get the cough. Calcium channel blockers, they inhibit voltage-gated calcium channels. So you'll block your L-type calcium channels. So you have dihydropyridine and non-dihydropyridines. The dihydropyridines block L-type calcium channels on smooth muscles in the blood vessels. So by blocking that, we don't enable the calcium calmodulin complex, which can form combined kinase and can phosphorylate actin to enable muscle contraction. So in your exam answer, you say you have your dihydropyridines and your non-dihydropyridine calcium channel blockers. Dihydropyridine calcium channel blockers bind to L-type calcium channels on vascular smooth muscle, prevent calcium influx, which inhibits formation of the calcium calmodulin complex, which prevents it binding to myosin light chain kinase, enabling its phosphorylation of your actin tract with myosin. So as a result, we get a let's change the song. that, constipation, it can cause headache, dizziness, peripheral edema. Vasodilation, it can cause headache, dizziness, peripheral edema. Vasodilation can cause agglutation. So it can cause a headache, dizziness, pedal edema, and then your beta-1 receptors, we can block them. And also blocks beta-1 receptors in juxtaglomerular cells, decreasing renin secretion, and also reduces the sympathetic drive centrally as well. So 3 ways that beta blockers work, and your non-selective is the funny ones. So the selective ones are the atenolol, metoprolol, and propranolol are your non-selective. Atenolol, metoprolol can cause bronchospasm, hypertension, AV block, increased triglycerides, and cause vivid nightmares. It can cause vivid nightmares, hypertension. It can cause arrhythmias such as a heart block, bronchospasm, and increased triglycerides. So that's pretty crazy. Okay, and you have your alpha blockers, such as your prazosin, that bind to postsynaptic alpha-1 receptors. They inhibit postsynaptic alpha-1 receptors. Postsynaptic can cause vasoconstriction. So your alpha-1 blockers include your prazosin, and they bind to alpha-1 receptors, inhibit it, causing vasodilation, cause postural hypertension, priapism. Damn, this was crazy. Maybe you can just listen to the rain sound. That's some crazy damn storm. Anyway, you can cause headache, dizziness. So your beta blockers can cause AV nodal dysfunction, predisposed to heart block. You can get a hyperglycemia. You can get vivid nightmares, bronchospasm, and hypertension, constipation, headache, pedal edema, and explaining. So your loop diuretics can cause a hypokalemia, thiazides cause hypokalemia, and your potassium sparing causes hyperkalemia, and then ACE inhibitors cause a hyperkalemia because they block aldosterone's effect, which is to get rid of potassium. So ACE inhibitors and your potassium sparing diuretics cause a hyperkalemia. APO is managed with the following medications. Acute presentation, he's taking a beta blocker, he's taking an ACE inhibitor, loop diuretic, which causes a triple whammy. So your furosemide also already dehydrates the tubules, and the NSAID results in afferent artery vasoconstriction, which was very important because they needed vasodilation to maintain GFR, as the ACE inhibitor causes selective efferent glomerular vasodilation. So we need to ensure that. So the ACE inhibitor causes efferent arterial vasodilation. Yeah. So you rely on constricting. Warfarin, beta blocker, insomnia, fatigue, increased triglycerides, cough, hypertension, cause ototoxicity, hyperkalemia, metabolic alkalosis, and digoxin inhibits sodium potassium ATPase channels. There's a buildup of potassium, and it can exchange with calcium, so it can cause calcium influx into myocytes. Potassium can efflux and increase cardiac contractility. So, digoxin mechanism of action. I need an image of this. Warfarin, it's vitamin K, but it actually inhibits. Right. Investigations. Whammy. They cause vasodilation of the efferent arteriole, so there's fluid already leaving, so you vasoconstrict. And there's vasodilation of the efferent arteriole. So they inhibit vasoconstriction of the efferent arteriole. Cause fluid to leave, which decreases the filtration rate. Huge. So volume, NSAIDs, dilates the efferent arteriole. So cardiac glycosides work with blocks in potassium ATPase channel. So potassium can't go in, sodium builds up, sodium exchanges with calcium, sodium out, calcium in, and causes increased inotropy. Right, so what's causing is acute presentation. Cardiac glycosides. Block that channel to increase intracellular sodium exchanges with calcium, calcium influxes, and that causes your inotropy. How would you manage these acute presentation? Stop taking that shit. What are the side effects of NSAIDs? Well, NSAIDs can, they inhibit cyclooxygenase. They can inhibit cyclooxygenase 1 and cyclooxygenase 2. Now, cyclooxygenase 1 is present in normal tissue. It's important for the development, it's important for platelet production of thromboxane, it's important for bicarbonate synthesis through prostaglandins, it's important for renal function, and thus we can inhibit COX-2, which causes the anti-inflammatory effects, but inhibiting COX-1 results in the craziest one I've seen before. Anyway, okay, so location of action, acute presentation, side effects. This can cause acute kidney injury, cause an interstitial nephritis. It can cause antiplatelet effects to increase bleeding risk. It can cause gastric ulcers. It can also potentially cause hematological toxicity, encephalopathy, and COX-2 selective inhibitors can result in decreased prostacyclin production, which can increase thrombotic risk. DVT. So provisional diagnosis, what do you investigate? Is vascular injury, can be through surgery, venipuncture, anything, hypercoagulable state. It can be through nephrotic syndrome, estrogen therapy, combined oral contraceptive, malignancy, and then circulatory stasis, so AF for example. And what is a Wells score? It's score, this is the pretest probability of DVT. It's greater than 2, there's a high likelihood of DVT. And there's factors like cancer, bed rest, if there is any tenderness along the deep venous system, calf swelling, previous DVT, and factor V Leiden mutation. So a mutation impairs the factor V binding site. Factor V Leiden mutation impairs factor V's binding site, so protein CNS cannot inactivate it. the prothrombotics. Factor V Leiden mutation is a mutation where your antithrombotic protein CNS cannot bind to factor V, and as a result, we get a hypercoagulable stimuli binding factor V. Okay, what investigations? Duplex ultrasound, use a CT pulmonary angiogram, coag studies. It's a high risk for PE, there's DVT, and duplex ABI, show ankle brachial index. Investigations, duplex, we'll be looking for sends and receives, transducer, blood flow, DVT, there's an echogenic band, non-compressible veins, absent flow, calf squeeze, ankle brachial index, dorsalis pedis, posterior tibial, show the ankle pressure and brachial pressure, and if it's low, it's blockage, if it's high, it's calcifications, increased blood pressure. Ankle brachial index. So if it's low, high pressure in the right foot divided by, so ankle brachial index. So if it's low, it's atherosclerosis. If it's high, there's some calcification. How do you manage a DVT? We can use heparin or clexane. How do they work? Heparin is vitamin epoxide reductase inhibitor. Fractionated inhibits fractionated 40,000 Daltons, and so it's an antithrombin 3. It's a direct thrombin inhibitor, activates antithrombin 3, factor 10, and inhibits factor 10. And you don't need monitoring, and it cannot be used in renal impairment. Does not need monitoring. Renal impairment. Compound fractionated heparin. So heparin is eliminated hepatically as well, so you don't need to worry about it for renal. You check APTTs and hazard vessel agent protamine, antithrombin 3, and 3 hydrogen monitor warfarin. Hydrogen monitor warfarin, iodine daily, APTT every 4 to 6 hours. You tell the patient you're going to give warfarin, there's necrosis, you form microthrombi, since it's initially prothrombotic. You give warfarin as a subcut, it can result in, so cranberry juices can activate warfarin, probiotic, risk of bleeding, pregnancy. For its plasma bound, we can displace warfarin. It's teratogenic, and it can cause osteoporosis. So warfarin can cause two things: osteoporosis. It can also cause skin necrosis and osteoporosis. Heparin can cause heparin-induced thrombocytopenia, and warfarin is recommended by CYP. So I can imagine crisavalvin, rifampicin, Cytotec P450. I just gotta memorize this shit now. P450. And you can have your Alvin, Bob's, you mentioned Bob's, phenobarbital, then rifle, rifampicin, carbamazepine, his name's Femi, and carbamazepine. So I shoot him. And these seizures can be carbamazepine. Clinical acinized ketoconazole. Cement fluid. Fluxes but begin the inhibitors cimetidine, some isoniazid. It's got the fluid. It's got the fluid. Fluconazole. That's fluoxetine. And phenocol. Warren pool. Phenocol. And phenocol. Fluoxetine. Ketoconazole. Keto diet. Ketoconazole. Anyway, I should not need to remember that. Anyway, let's go on. What are the complications of heparin therapy? Heparin can cause bruising, hypoaldosteronism. It can cause anaphylaxis or heparin-induced thrombocytopenia. Heparin can cause a hypoaldosteronism. Warfarin CNS, RNS, and Warfarin S is more potent. Warfarin S is stronger. Warfarin RNS. Warfarin S is stronger. Irreversible drug interactions. Aldosteronism. Gone through all of that. Anyway. Myocardial infarct. What drugs can be avoided in myocardial infarction? NSAIDs and glucocorticoids are infarct healing. NSAIDs and glucocorticoids, they inhibit thrombus formation. NSAIDs impair platelet plug formation. NSAIDs inhibit plug formation. And glucocorticoids impair healing. Right, so close that. That's all your farm. So I finished cardiovascular. Farm, second pass cardiovascular. Then come back here, briefly notes, heart failure, cardiac sympathetics, atrial fibrillation. Turn into a page. else I'm trying to block here is non-dihydric. The second line. Second line. Dihydropyridine. So channel blockers. Digoxin. Digoxin. And then you can use phenylation pacing. And then for rhythm control, I will use rhythm control. You can use amiodarone. Suitable. Come back here. Alright, we're done. How many hours did I study for? 4 and a bit.
the other inflammatory types of arthritis, usually peripheral joint symmetrical, non-erosive. This is actually quite helpful and something you probably have come across before already. So to diagnose someone with lupus, it's a combination of both clinical and laboratory criteria, where you need at least 4, and of which 1 needs to be a clinical and at least 1 needs to be laboratory. So you can't just have pure clinical features, you also need laboratory evidence. And the typical mnemonic people like to use is SOAP brain MD. But essentially, this patient has got most of these features anyway. But just a mnemonic in case it's helpful. You had a good crack at this one, so
I had no clue.
It is immunofluorescence, okay. Nice, nuts and brights, and it's one of the key immunohistochemical techniques these days for identifying autoantibodies. It's a key tool that's used in rheumatology to diagnose various conditions. And the type of staining in this case is called homogeneous. So you can see all the little green dots, they're all lit up in green. Essentially, the whole cell is lit up in green, which is why it's called homogeneous. The other way to describe will be diffuse. And this type of pattern is suggestive of antibodies against double-stranded DNA or histones, which is distributed all throughout the cell, which is why the whole cell lights up.
Yeah.
And likely causes include many other things. Honestly, you're not expected to know this, but this question was asked in my cohorts and the cohorts just above you. So it looks like sometimes the examiners do want you to have some awareness of this. It's probably a good idea if you just know some of the phrases. So I think you said there is nucleolar pattern staining. There's some other buzzwords that correspond to other different features. So it's probably a good idea if you have any more space left to just memorize some buzzwords for these things. But I think as long as you recognize that's immunofluorescence, you probably get a full mark for that station. Okay, so antiphospholipid syndrome, I won't dwell on this for too long. So there is a plot mnemonic that summarizes the features that we see in patients with antiphospholipid syndrome, of which obviously the most significant side effect is coagulation defects. So it gets both arterial and venous clotting. There's obstetric complications, especially if the patient is a female. And as a result of the coagulation defect, these patients often thrombocytopenic as well. And you've mentioned D3 antibodies, so anti-cardiolipin, lupus anticoagulants, and anti-beta-2 glycoprotein 1 or B2G1 antibodies. And obviously, as you start clinical medicine or when you go into internship and you have to order these bloods, all of these things actually start to make a lot of sense because I've had to order a lot of these bloods for patients.
Yeah.
Usually bosses come around and just go, I want a prothrombotic screen. And you're like, what the heck are you talking about?
Yeah.
And you go all the stuff and you're like, hey, I'm going to do my meds.
Right. So I guess my question was, so if you're forming antibodies to phospholipids, does that initiate the coagulation cascade? Is that why it's prothrombotic?
So it's actually very complicated, and I'll be honest with you, I do not know. I don't want to give you the wrong answer. I no longer remember the precise mechanism.
Yeah.
So I'll probably ask you to look into it.
Yeah, sure.
It's been too long. Okay, look, lupus nephritis is so complex to the point that even the advanced trainees in nephrology aren't expected to fully know what they are. On my heart, there are 6 different types, and I think you are probably correct in that the most common type is rapidly progressing, which is very unpleasant. But really, the focus of this question is to recognize this patient may have lupus nephritis, and the way to diagnose it is really via a kidney biopsy, which is the definitive way. I was a bit cheeky and grilled you on what other tests would you do on a sample. It's more of a specific question about renal biopsies. So typically when you get a specimen intraoperatively or a biopsy specimen, everyone almost always gets histopathology, which is the process of looking at tissue architecture. For renal biopsies, we go one step further and we use immunofluorescence to stain for antibodies that may be present. And we also look at the specimen under both electron microscopy and light microscopy to look at various things. But Again, I don't expect you to know this at all. I think it's just a bit of a bonus question.
Yep, electrolytes. Got it.
Yeah, but that's pretty much most of lupus. So I think you need to definitely know the diagnostic criteria. So rank MD, know the existence of phospholipid syndrome, have some basic understanding of immunofluorescence, and you'll be okay.
Yep.
All right. Oh yes, we should probably talk about the specimen stuff as well. So I think, okay, so I asked you about blood cultures, which is really good. I think you pretty much mentioned everything correctly. I will definitely go and read up about the contents of the blood culture bottle.
Yeah.
So it was completely correct. So you've got an enrichment broth, which is normally a beef broth, but obviously depending on the manufacturer is different. So you've got some protein-rich broth that's going to encourage bacterial growth. On top of that, you've got other added agents. So obviously in the aerobic bottle, you have oxygen. In the anaerobic bottle, you don't have oxygen. Some of the other really important things include antibiotic resins, and there's a specific name for it which escapes my mind because it's quite a long name. It's called SPS or something. Essentially, it binds to other foreign materials as well as antibiotics to try and promote the growth of that bacteria. As you imagine, a lot of these patients from whom we take blood cultures from have already been started on empirical antibiotics. I mean, ideally not, but obviously you don't want to delay antibiotics to take a blood culture. Yeah. So sometimes these patients have received a shot of gentamicin already and taking blood culture. The blood culture bottles would contain an antibiotic binding resin to try and wipe out the antibiotics so that we can get the results in the culture bottle.
Is that in both of the bottles?
Correct. So both bottles. So both bottles are very similar apart from the difference in oxygen and maybe one other thing, which I no longer remember. But otherwise, the medium is very, very similar.
Okay.
And you're right. So ideally, we'd like to take 3 sets of blood cultures in different locations and different time frame. In reality, we only really take 1 set of blood culture. Obviously, unless the patient is really, really septic, then we might take 2 sets. Or if infectious diseases specifically consults, then they will usually ask for 2 sets. But usually in emergency or in a general inpatient setting, we just take 1 set of blood cultures.
Yeah, okay. So I had a question, when structuring lab, when they just say, tell us about a lab test, do we start with like indications and then methodology, or do we jump straight into methodology? How would you structure it?
Yeah. I guess what's important to keep in mind is you only probably have a maximum of 2 minutes to spiel whatever you want to say. So I would avoid spending too long on indication. So I'll literally spend maybe 10 to 15 seconds tops on the indication. So blood cultures is indicated in these situations, and the method that I will take a blood culture would be using aseptic technique by firstly collecting all the necessary materials and then blah, blah, blah. But usually by that time, the examiner would have interrupted you with very specific questions. Usually good examiners will do that because they know, a question like, tell me about this is really, really broad. So they'll normally redirect you at some point in time.
Right.
But yeah, they'll look at the clock and rush you on. So even if they don't, which is why it's important that you have a really succinct summary, because there are some examiners that will just let you speak, which is quite dangerous. So I'll definitely have a shortened version of these spiels where you can sort of race through them in a minute and a half or so. That's sort of how long I would time myself.
Yeah, makes sense.
Yeah, but usually they will ask very, very specific questions. Yeah, okay. Let's move on to station C. So you mentioned the chronic cholecystitis. So I was, again, quite broad with my questions, but, in the exam setting, you might be asked to describe, okay, what are some of the macroscopic features of the specimen? So instead of talking about indications, you go and talk about the macroscopic appearances immediately. And that's the other thing. If the examiner asks you a very specific question, make sure you don't waffle around and try and include some other superfluous things. Make sure you just address their questions because you've got quite limited time. So don't waste much time on the specimen stuff.
Yeah.
I had no real feedback for the specimen. I think everything you said seemed pretty sensible. Okay. We'll talk about this breast cancer station. Definitely need to read up because breast cancer is a very commonly assessed station. It's also really common in the community as well. So it's a very topical condition. Look, this is very controversial. And I put it here intentionally to remind myself, because in your situation, I would have said the provisional as breast cancer. And with these cases, sometimes there is no one right answer. So as long as you're able to justify your answer, you will still get a mark. So obviously, you justify your answer by saying it's an ill-defined lesion in someone with a history of with a family history of breast cancer, which is why your provisional is breast cancer, and I think that's justified. At the same time, you can also say this is fibrocystic change, given that this patient is young and that the most common breast lump in this age group is fibrocystic change. And this lump can be hard, ill-defined, and have a ropey texture as well. So I think either way is fine. There is a huge list of differentials with breast cancer, which can seem very overwhelming. But the way I like to characterize it is to split it into three main categories. So reactive change versus fibrocystic change versus neoplastic change. Okay. Reactive changes, we're talking about infections, inflammation, like abscesses and mastitis. Fibrocystic change is the most common category, and within that we have non-proliferative fibrocystic change, which confer no increase in risk for cancer. But we also have fibrocystic change with proliferative phenomena, which will lead to increase in risks of breast cancer. And you can see some examples there. And then finally, we have neoplastic change. And neoplasms can be benign neoplasms. We're talking about metaplasia and other pathological changes that don't lead to cancer. So fibroadenoma, papillomas, and things like that. But obviously, the main category in neoplastic change is breast cancer. So we've got ductal and lobular. And then there are some other other more rare neoplastic diseases like Paget's disease of the nipple and inflammatory breast cancer, which are very, very nasty conditions. So I think the way I would characterize my differentials will be, we've had reactive changes, fibrocystic and neoplastic. Within fibrocystic, there are those with proliferative changes and those without proliferative changes. And within neoplastic category, there's benign lesions and malignant lesions. I think that's probably the way I'll structure differentials.
Yeah, makes sense.
It is a very broad topic, so I'll leave you some time to actually just revise in your own time. Okay, triple assessment. This is actually really, really important. This is something that was definitely taught in first year in AEA and third year. So
yeah, forgot it.
You've got to know this, because I think this is a really easy mark, and it'll be a shame to lose marks in this section. So triple assessment refers to clinical exam, imaging, and histopathology. And you need all three to make a diagnosis of breast cancer. It's probably the most well-researched clinical assessment for any condition. There's heaps of systematic reviews out there and a Cochrane study. So it's a very well-recognised thing. So when it comes to triple assessment, everyone knows we're talking about breast cancer. Won't dwell on this for too long. So mammography or X-ray usually ages 35 and above. And that's because the older you get, your breasts becomes more dense and more becomes more calcified, which is why X-ray is better than ultrasounds. But it is dependent on population. So, for example, in Chinese or Asian population, females usually have more fibrous, more dense breasts. So a lot of those patients would essentially get mammograms all throughout those dogs. So there is that distinction. And in terms of pathology or biopsy in the triple assessments protocol, I would definitely have some understanding of the differences between the different biopsy methods, which is very similar to the other stations, when we talk about lung cancer, cervical cancer. So make sure you know about the pros and cons between FNA or incisional and excisional biopsy. It's a pretty common question as well. All right. Look, you can say yes or no. I think as long as you can justify the reasons why. But obviously, in this case, the FNA and the mammogram returning a negative result is usually sufficient. But this patient will definitely need further surveillance later down the track. So they might need repeat imaging in a year or so and things like that. We kind of skipped that question, but essentially, yes, there are certain fibrocystic changes that can promote or that can confer an increased risk of cancer, and that's in those with fibrocystic change with proliferative changes. It's a bit wordy, but we won't dwell on this for too long. Right. right. All right. Again, this is very generic cancer, sort of basic cancer pathology. So with any cancers, when it comes to a prognosis question, the way that I will always structure it is not jump straight to staging and grading, but take one step back and say there are both patient factors and human factors that can affect prognosis. As our patient factors, we worry about age, normal functional status, comorbidities, and their psychosocial supports. And in tumor factors, we talk about staging, grading, the subtype, and the molecular status. Molecular status in breast cancer, that's referring to estrogen and progesterone receptor positivity, and also the HER2 positivity status as well. But this is a pretty generic framework for any cancers. So again, another pretty easy mark to get.
Okay.
And look, if you get breast cancer in the exam, it should be a pretty sweet game because the questions they ask are usually pretty similar to these ones.
Yeah.
Okay, let's go to station D. You did really well for this station. I really didn't have much to say, so I won't spend too much time going through these slides. But very good, you know the cutoff. That's really important. Biggest difference between T-score and Z-score, as you said. So T-score is comparing patients to essentially a young, healthy population, usually someone that's 30 years old, corrected for sex, ethnicity, and weight. And obviously, someone who's 77, you would expect those to be worse than someone who's 30 years old. In terms of how bad it is as a comparison, we use standard deviations to grade that. And if it's below 0.25, negative 2.5, and it's considered the patient has osteoporosis. Whereas Z-score is comparing the patients to a similar population that's age matched. So as you can imagine, this patient's Z-score might be very similar or might be in the normal range because most 77-year-olds will have some degree of osteopenia, if not osteoporosis, which is why T-score is good for old people, Z-score is good for young people who are worried about secondary causes of brittle bones.
Makes sense.
Because in young people, you would expect their bones to be normal. So if their Z-score is abnormal, then there's something wrong.
Yeah.
Okay. There's some risk factors, which you've all mentioned, nothing particularly interesting. And then secondary causes, I think you've mentioned all of them, which is really good. The only thing I would say is just remember structure. So if there's a certain way that you can structure your answer, try to give the examiner something of framework to hang your answer on, because you'll just make things sound more polished. Yeah. But I think you mentioned all these, so all good. Okay, so in terms of drug classes, so there's hormonal versus non-hormonal, and those are the main categories, which again you've all mentioned, which is really, really good. These are just random slides I pasted in that you can just have a read in your own time, but essentially you are expected to know the general indication, mechanism of action, and side effects for all these drugs, but I would definitely know the nosumab and bisphosphonates really, really well because they are the most commonly used drugs. And a very common misconception, which I think you also displayed, is osteonecrosis of the jaw is a very rare side effect, but it's not purely seen in bisphosphonate use. It's also seen in patients who use denosumab. So these patients can get osteonecrosis of the jaw as well. Very rare, but they can. And with bisphosphonates, the other really important side effect to know is atypical femoral fractures. So for reasons that we don't really understand is that these patients, for whatever reason, get mid-shaft femoral fractures, which as you can imagine, usually only occurs in patients who've undergone a very, very traumatic events, such as a high-speed motor vehicle accident or fall from 6-7 levels. But these patients, for whatever reason, get mid-shaft femoral fractures. That's low impact. Again, very rare, but it does happen. So I think it's important that you are aware that this can happen. Some of the examiners will press you for this answer.
Right.
And the other really important thing is reflux. So bisphosphonates are a type of medication that cannot be crushed. Patients can also not lie down in the 30 minutes after they have this medication because it can lead to esophagitis, and in very severe circumstances, you can actually perforate the esophagus, which is very nasty. So the general patient education is, if you take enough bisphosphonates, make sure you stay sitting upright for 30 minutes, so that the medication goes to your stomach,
Yep.
lying down. Yeah, I think those are really what I really wanted to say. Nothing really exciting. I think some of us might want to ask about PTH analogs. You don't really need to know too much about this, but the I guess the indication where you might consider using PTH analog therapy is in patients who have taken bisphosphonates and denosumab and have had further fractures on them. That's sort of the only time where you will consider therapy. So the first line's bisphosphonates and denosumab, or if you're a woman and you're young, then you might consider hormone replacement also. But PTH is absolute last line. So you've got to try some other medical therapy that's failed before trialing PTH therapy.
Right, okay, makes sense. Risk of osteosarcoma.
But yeah, lots of information overload. I won't go through all of these. Okay, so short answer, this is semi-selective. HRT is not, SERM is made in the laboratory, and HRT is normal. Your normal biological hormone. And obviously, this patient being 77, you wouldn't use HRT because she's old, she's at risk of breast cancer, cardiovascular disease, and things like that, which we all mentioned, which was really good. Okay, good job. Station D was really good. Okay, and then we come to anatomy. So, right side of pneumothorax, we've identified that. You've given some pretty good differentials for respiratory distress, and examination was fine. And then we come to labeling the CT.
Oh,
and then
no.
you had a very good attempt.
A for
there
effort.
were some errors. Look, I mean, the easiest way is really to think about what level of the chest we are looking at. So what I will normally look at is you want to see the location of the aortic arch. So if you can see the aortic arch, you're probably above at or above T4. If you see two big circles, one at the back, one at the front, you know you're below T4 because you're below the arch. So you can see a descending and an ascending. So the way I like to structure, the way I like to orientate myself in these scans is I look at the aorta first to see where it is sitting. So if you see a circle at the front, a circle at the back, then you can identify those guys. So that's ascending and that's descending aorta. And then I look at the windpipe. So if you see one black hole in the middle, then you know you're still in the trachea. If you see two black holes, then they're the bronchi. And from there onwards, everything else is just, thinking about what relations are next to these structures. So there is a pulmonary trunk that's nearby the ascending aorta, which is C. And pulmonary trunk was split into the left and right main pulmonary trunk. And which between the pulmonary trunk and the aorta, you have the SVC. So A is actually pointing at the SVC.
Oh, right.
That's what A is pointing at. And I think, to be honest, you actually got all these apart from A and F. F is probably the most dodgy structure. Basically, anything that's behind the bronchi can only be two things. It's either the esophagus or it's the azygos vein. Unfortunately, this arrow isn't very clear, but esophagus is that diamond thing immediately touching the bronchi.
Yeah.
But the arrow actually stops at that weird structure behind the esophagus, so it's actually pointing.
Yeah, okay.
But yeah, I mean, I will probably take esophagus anyway because this is a pretty crappy picture.
So zygus is behind the esophagus anatomically.
Yeah, normally. But I will definitely go through the anatomy modules and we'll just familiarise yourself with the different levels of the CT chest scan because it's a pretty common question.
Yeah. Is it pretty much every biomed you'll get one CT?
Hard to say. Some years you might not, and you get a physical model in front of you. So you might actually get a model of a bronchi, and you're asked to.
They told us this year there's no models, so they'll be all laminated sheets.
Okay, so I guess it's possible you might get a scan. The most common one is probably CT brain, followed by a CT chest. So I would familiarize myself with the basic anatomy of the CT brain. So looking for strokes, lesions, and things like that. Those are probably the most common findings that they'll expect you to know. And also just joint fractures, so like shoulder dislocations, rib fractures, and things. They might expect you to know as well.
Yeah.
But not to the extent of summarizing a scan because you have no time for it.
Yeah.
All right. Welcome to this lovely chest X-ray. I can tell you right now, this chest X-ray is far from normal.
Oh, sheesh, what did I miss?
You missed a few things, but yes, if this happened in real life and you said this was a normal X-ray, sent the patient home, I think your emergency consultants would be quite upset.
Yeah, no. Sheesh. Alright.
All right. Look, the chest X-ray is a complete other topic that, maybe next year when we have time, we can go through how to read a chest X-ray properly, hopefully in real life as opposed to over Zoom or Teams. It makes it really difficult. And honestly, in this biomed setting, you're not expected to go through an A2E, a very thorough appreciation of the X-ray, because all examiners most likely are not clinicians. So look for the main thing. If there is a scan, there is something very, very obvious. So people look at different things. First, I tend not to look at the lung windows because, usually the most obvious pathology is in the lung window. And when people see a pathology, they just go, okay, I've seen what I see, and they might miss other things. What I normally like to do is look at the bones. So look at the shoulder first. Look at the glenoid joint, glenoid socket to make sure there's no fractures, dislocations. Then you look at the clavicle, and you go through each rib, just looking at the borders. So when you look at a rib, you're not looking at what's in the middle. You're looking at the cortex. So seeing if there's a nice straight line going across. So if you look on the right-hand side, going across, you can see there's a fracture there.
Yeah, the fracture.
Fracture here. So they've got extensive right-sided rib fractures. So definitely not a normal X-ray.
Sheesh.
And the other place I like to look at is the subcutaneous areas. So over here in the skin, you don't want to see any black areas because remember, black in the X-ray means it's either liquids. So on this left-hand side, you can see it's nice and whitened out, which corresponds to fat. Whereas on this side, hey, what is happening here? So all of that is subcutaneous emphysema, which is abnormal. So when you palpate this patient's chest wall, you might actually palpate crepitus. If you ever get a chance, because I think you were on trauma before, but I'm not sure if you're still on trauma.
I've palpated subcut emphysema. It's like bubble wrap.
It's a very strange sensation, but once you've palpated it once, you will never forget what it feels like.
Yeah.
Pretty significant subcut emphysema there. And then the next thing to look at really is to look for pneumothoraces. And they can be really, really tricky, especially if they're small. But what I normally do is look at the edge of the lung just to see if you can see any markings. So normally pneumothoraces don't get as bad as the one that you see on this X-ray. And you sort of compare both sides because it's very rare to get bilateral pneumothorax. It's very, very rare. So if you look at the left-hand side, you can see the wisps of lung markings extending all the way out to the edges. You can still see some lung markings on the edges. Whereas if you look at the sides, they tend to disappear. Look, this X-ray is pretty shitty X-ray that I fished out on Google, which isn't really representative of what you see in a real setting. But if you follow where my mouse is, you can see the trace of the lung that's collapsed. I'm not sure you can appreciate it.
I don't think I can see your mouse, but I get the key point. You're looking at the markings that are extending to the end, and it's not extending to the end on the right side. Is that right?
Yeah, exactly. I'll see if I can trace it out.
Yeah, I see that.
So if you follow that below and above, you can see that line.
Is that the lung?
So that's the lung that's collapsed.
Sheesh.
Before it becomes a bit faded when it gets to the hilum. It's not the best chest X-ray, but essentially this is a pretty big pneumothorax. I wouldn't be too concerned if you still can't really identify pneumothorax very well. I don't imagine they will give you a chest be looking as difficult as this one. If anything, it'll give you one with a huge rib fracture or a huge opacification, because the point of Biomed isn't clinical medicine. So I think if you do get a chest X-ray, it will be something really, really obvious of it. So don't worry too much.
Okay.
Yes, always be careful when you look at a chest X-ray. It's
Yeah.
not full on.
It'll rarely be normal. That makes sense.
All right. Okay, so look, triangle of safety is very important, and you know the landmarks, which is really good. The situation where you would use the mid-axillary line in the second intercostal pace is in emergencies. But I think you actually said that you would use triangle of safety for emergencies, which is not quite
right.
The reason why we use mid-clavicular line, the second intercostal space, is because it's a very easily accessible area. Usually patients who have gone through traumatic events are usually lying flat on the ground. So if there is a pneumothorax, air will rise up. So you'll puncture them in that location to try and decompress that lung. So emergency needle decompression in the mid-clavicular line in the second intercostal space. Once you've stabilized the patients, you will want to put a definitive chest drain in the triangle of safety, which you've said already. So remember, you want to insert the chest drain on the top of the rib, not below the rib, because the neurovascular bundle travels in the inferior margin of the rib.
Yeah.
So make sure we don't get confused by that one.
Yeah. Super inferior.
Right, and this is a pretty good diagram in terms of what the structures pass through. It's okay. To this day, I still get confused. I still confuse my intercostals with the oblique muscles.
Yeah, I was almost finished saying that.
Honestly, it's really the same thing. It's just in different locations. It's given a different name. But obviously, you can't say oblique muscles on the chest wall. But yeah, that was really good. This was a new question last year, where essentially parietal pleura and visceral pleura have different innervation. And parietal pleura has is sensitive to pain. So somatic pain fibers innervate the parietal pleura, not the visceral pleura. And it's a very similar concept to the peritoneum. So we'll take appendicitis as an example. This is also the reason why in appendicitis that's initially localized, you get a visceral pain, which is poorly localized, very vague pain. And the moment you have irritation of the parietal peritoneum, you get this very sharp, very well localized pain. And that's because the parietal peritoneum is also very, very sensitive to pain. So it's very similar concepts.
Yeah.
So the parietal layer is always pain sensitive, and the visceral pleura is not pain sensitive.
Yeah.
And they have different nations. Okay, I think that's it. Good job. I think I'm doing really well, Prithvi.
No, I need to revise. I still have about 17 cases left. Breast cancer was one of them, and I just need to quickly do a second pass. But I think I've got it planned out.
Yeah, I think you'll be fine, man.
What would you suggest now? Like in terms of practice, what I was thinking was just going through, 4 or 5 cases a day, again and again, focusing on the innate and farm, because I feel like the path is all, like you can derive a lot of it, explaining atherosclerosis, but like farm, it's much of memorizing, and same for innate. So what would you say now to do 25 days out?
Yeah, look, everyone's different, so I think you know yourself the best. So it's definitely a good time to focus on where you think your weaknesses are, or areas where you think you might benefit from more work. So putting some more time into those areas. But it's also a really important time to just start
but I might wait till it's sundown and then I will leave. We've done 5.5 hours today. Not bad, not bad at all. Bad at all. I'll probably hop on later as well. Mammillary body, anterior thalamic nucleus, cingulate gyrus, hippocampus. DH status. Central gyrus, postcentral gyrus. Mature at the base, stretching. Pain sensitive structures. What is your memory loss? What type of seizure did he have? Jacksonian seizure, 51 from the bit. So it stretches from the distal to the periphery. So your hands and your mouth and your tongue. Distal palm to the ipsilateral face, the distal limb of the hands to the ipsilateral face. That's progressive activation of neurons from the medial to lateral compartment of the brain. History and exam. So this is there is midline shift, there's vasogenic edema, effacement of the ventricles, and there is a hyperdensity. It's well circumscribed. We call this a ring enhancing lesion, and the differentials for ring enhancing lesion are that of demyelinating disease such as multiple sclerosis, radiation necrosis, tumor metastases, abscess, glioblastoma, infarct, and contusion. Caesar septum pellucidum, there's peritubular edema, there is a ring enhancing lesion with central necrosis. We've gone through magic. The tumors, each of the cortical areas. So, twitching and weakness of the face and upper limb. So, if there is motor changes in the face and upper limb, that's precentral gyrus, primary motor cortex. Face is lateral to the. So we have our leg, our arm, and then our face. So face is lateral to the arm in the motor homunculus. So it could be a more lateral precentral gyrus. And there are some terrible headaches that can be due to the stretching of tissues in the brain, such as the meninges, potentially the venous and arterial system, meningeal arteries, dural venous plexuses. dura, venous sinuses, meningeal arteries, and cranial nerves, sensory cranial nerves. Your anatomy, personality is limbic that projects to the prefrontal cortex, and memory is short-term working memory in the dorsolateral prefrontal cortex, and then your mammillary bodies are important in memory formation, and they are part of the limbic system. So mammillary body, anterior thalamic nuclei, starts known as the hypothalamus, important emotional regulation, was then modified to the limbic system by including the limbic system following addition of the amygdala. Pathology. Secondary tumors, Mr. Pound. So melanoma, radiation, breast, bowel. Lead kettle is PB. Secondary tumors come from melanomas, radiation tumors, breast, brow. It can be primary or metastatic. It can be metastatic. It can be from the lung, breast, bowel, renal. It's melanoma, renal, and then lung, breast, brow. Renal. Mr. Pound, some metastases can be melanoma, renal, lung, breast, brown color. Lung, breast, bowel. And let's set our timer to being so you can have melanoma, lung, breast, bowel. So it can be metastatic, it can be melanoma, kidney, lung, breast, bowel. It can be gliomas, tumors of different cells. We can have gliomas, oligodendrogliomas, epidermomas, produce CSF, your astrocytomas. You can have a neurocytoma, which are very rare, medulloblastoma, meningiomas, and CNS tumors tend to lack precursor lesions, leaving due to certain conditions, and then specifically the astrocytomas, you can have there's grades from 1 to 4, well circumscribed, all the way to heterogeneous, poorly defined lesions. And so we have your pilocytic astrocytomas, we have our diffuse anaplastic, which is high grade, and then your glioblastoma. So your astrocytomas, they're infiltrative tumors of glial cell origin. There's various types, grade 1 to grade 4. There is your pilocytic, diffuse, anaplastic, and glioblastoma. Pilocytic, diffuse, anaplastic, glioblastoma. So explain the pathology behind brain tumors. So brain tumors can occur due to metastases or central malignancies. If they are from metastases, they tend to be from melanomas, kidney, lung, breast, bowel, and we can also have primary tumors of the brain. So metastases are much more common. With primary tumors of the brain, we can observe malignancies of different cell types, and this can include malignancy of glial cells or of the neurons themselves, which are much less common. Of glial cells, we can have tumors of your meninges, so meningiomas. We can have tumors of the astrocytes, or an astrocytoma. We can have tumors of the ependymal cells, which secrete your CSF, and that can be an ependymoma. We can have tumors of your oligodendrocytes, oligodendrogliomas. Regarding astrocytomas, it can be graded based on 4 grades. There's grade 1 to 4. Grade 1 is your pilocytic astrocytomas. They're well circumscribed, typically seen in children. And then we have grade 2. grade 2 astrocytomas, and these are your diffuse astrocytomas. And we have grade 3, which is your anaplastic, grade 4, which is your glioblastoma, which is characterized by vasogenic edema, necrosis, and there is polydefined, etc. So microfractures, which you do. I would expect cervical spine injury as the nexus criteria, so mnemonic is NSAID. So neurological deficit, spinal tenderness, altered consciousness, intoxication, disrupting injury. And what level is a CT taken? You locate the odontoid. For the landmark spinal imaging, you identify the odontoid. Cervical spine anatomy. 4 typical cervical vertebrae. Spring-like disc shape, neurodontoid process. C2 is your C1 is your atlas, C2 is your axis, C7 is your vertebrate prominence. It's not bifid in nature. So C7 is not bifid. So we have your atlas. Your pars interarticularis, you have your inferior articulating process, your transverse process, you have your dens, superior lip, tiger, physial joint, inferior lip, groove further spinal, nerve inferior articular facet. You have a transverse process of the posterior tubercle, the groove. So we have our mandible, we have our sternocleidomastoid, lateral massive C1, OCI internal jugular vein. I can't interpret these. Hyoidine, sternocleidomastoid, trapezius. Investigations which you do. CT and then X-ray. Previews lateral AP and odontoid. Open mouth to view the cervical spine. Lateral AP and odontoid. You need 3 views of your X-rays. Lateral AP and odontoid. Interpret them. This would be your C2, C3, C4, C5, C6. So C4, C5. So if you have it, C5 compatible with life, phrenic nerve is supplied. C4, difficulty breathing. You have quadriplegia. You can have breathing total parasol, wrists, hands, trunk, and legs. C5, you can slightly abduct the arms. And then you can't flex. And you can have limited bowel or bladder control. There's limited arms, there's weakness and extension. C8, loss of dexterity in the hands. No control. Basically, 1 to 3 is phrenic nerve. 5 is adduct. 7 is it can move the biceps. 8, corticospinal tract. For the corticospinal tract, it begins at the precentral gyrus of the primary somatosensory cortex, travels through the posterior limb of the internal capsule, travels through the midbrain and through the ventral pons. Why would it move through the damn thalamus? So it travels the internal capsule, the midbrain to the medulla, and then 85% of it will decusate, and it will synapse at its level of exit. So it will travel all the way to its level of exit, and then it will synapse somatosensory. It's your corticospinal tract. And then your dorsal column medial meniscus, because your first order neuron travels in the dorsal column of the spinal cord. It travels from the dorsal root ganglion to the Grace alpha and cuneate fasciculus up all the way to the medulla. So anything below travels in T6, which is your Grace alpha fasciculus. Anything above T6 is cuneate fasciculus. Second order neuron is called the medial meniscus, and it synapses at the medulla. It will decusate, and the heavily myelinated decusation is called the medial meniscus. And it will move to the VPL nucleus of the thalamus, and will go from the VPL nucleus of the thalamus to the internal capsule posterior limb. And what is the mechanism of fracture? There's two types of ways we can fracture the cervical spine: the Jefferson's and Hangman fracture. So a Jefferson's fracture, a diving injury into loading, and that can occipital condyles be driven into the lateral masses of C1. Occipital condyles can shatter the lateral masses of C1. The Hangman's fracture, which is paralysis and often death. Forced hyperextension of the head, distraction of the neck. Extension by pars interarticularis. The atlantoaxial joint. So it's your pars interarticularis, superior inferior articulating facets. Extend pars interarticularis. Cervical anatomy. very good. How would I start doing that? So your thoracic aorta, that's going to be your thoracic aorta. B is your esophagus. C is your esophagus vein. E is your interventricular septum. It's your coronary sinus. Restrictive organs. You have your inferior vena cava. Start with what I know. Left over the diaphragm. Stomach fundus. C is the liver. D is your left ventricle. E is your right ventricle. It's your left atrium. Pelvic structures, your spleen. B is your stomach fundus and body. C is your inferior vena cava. Your splenic and your superior mesenteric vein form your portal vein, and that will enter the liver. Thoracic aorta. Here's your liver. Stomach fundus. Here's your stomach body. C is your pylorus. Here's your spleen. E is your caudate lobe of the liver. Lobe assigned quadrate lobe. Caudate lobe. So your quadrate lobe is inferior, your caudate lobe is... Yeah, your caudate is at the top, your quadrate is underneath. Caudate, quadrate, bare area of the liver. Falciform ligament. F is your gastrohepatic ligament. Connects these two. I don't know. It's a right kidney. It's your right cross of your diaphragm. Vertebral column. It's your cross. The diaphragm. Yeah, and then C is your splenic artery. Well, your splenic artery should be coming off the aorta, and and traveling to the spleen. So C would be your splenic artery. D is your, this should be your body of your pancreas. Your portal vein is actually front. Pancreas. So it's here. And then F is your common hepatic artery. Trunk splenic artery, it's going to the liver. Guessing that. So if that was your common hepatic, what would that be? Maybe your left gastric. Anyway, what do we do now? A is your gallbladder. B is your splenic flexure of your colon. B is your splenic flexure of your colon. Your splenic flexure is your right colic flexure. No, your left colic flexure. What am I saying? Should be a splenic flexure. C is your left kidney. D is your splenic vein. Usually from E is your left crus of your diaphragm. F is your abdominal aorta. No clue what I'm doing. Second part of duodenum. A is your second part of your duodenum. B is your left renal vein. It's coming from your, see. Your duodenum is first, second, third. First, second, third, fourth. First, second, third, fourth. Showing superior. I don't know, C is probably the fourth part. D is your head of pancreas. Don't even see my pancreas. Is that pancreas? E is your bile duct. Your gallbladder. It's your fourth part of your duodenum. So outside of the body. Hepatic flexure. Lumbar vertebra 3. Hepatic flexure is your right colic flexure. And so we have a descending colon. So your descending colon should be this. Your transverse colon should be this. I think that's small intestine because you can see these plicae circularis extending all through the lumen, possibly. Your mesentery, probably this. Mesentery is a greater omentum. The mesentery is holding the organs to the bowel. So that's probably the mesentery. D is your right psoas major. Show you that psoas, right? It's your rectus spinae, quadratus lumborum, and your psoas muscles. And E should be your left quadratus lumborum. And F is your hepatic flexure, should be somewhere right here. Next. 18. Uncinate process of the pancreas. ascending colon. It ascends the right side, so there should be ascending colon. B is your onset process. Pars interarticularis, lateral bodies of the C1 vertebra. What are the stabilizers? Your transverse ligament. It holds the odontoid process. The anterior arch. Transverse ligaments are primary stabilizer of the atlantoaxial joint. Ruptures. Dense central parts. So then you have your alar ligaments. Odontoid to occipital condyles. Your odontoid. Your alar is your odontoid to your occipital condyles. Your transverse ligament is your odontoid to your anterior artery atlas. Apical ligaments. Odontoid frame magnum. Alar is odontoid to the occipital condyles. Then to the foramen magnum. Apical is to the odontoid foramen magnum. Alar is odontoid to your condyles. Transverse is odontoid to your atlas. Ischemic stroke. The parts here. 23 is your falx cerebri. Your caudate. 28. Anterior limb of the internal capsule. 28. Posterior limb of the internal capsule. 25 is your lentiform nucleus, caudate and putamen. Here's your caudate. It extends. The internal capsule travels between it. The caudate will end at the amygdala, so that head, body, and it will end at the tail of the caudate, close to the amygdala. So you have your caudate, your thalamus, your anterior, posterior, the internal capsule, your lentiform nucleus, which consists of your putamen that protects the globus pallidus. Here's an external and internal. GPE, yeah. We have an external capsule. And then we have a colostrum. The centers for personality. Frontal lobe, dorsal prefrontal cortex, and limbic system. Frontal lobe, limbic system, it's emotion. It's your memory bodies, your anterior thalamic nuclei, cingulate gyrus, the hippocampus. Blood supply to the visual system. It's a very common question. I get asked again and again. To the visual system, is beginning to the eye. We will have semionopia, Myers and Baum's lip, Myers and Baum's lip. Retina is central retinal artery. Optic nerve is your ophthalmic artery. Optic chiasm is branch of the internal carotid. Your optic tract is your anterior choroidal, PCA, MCA, PCA, and MCA. And so your optic tract. So this is your central retinal artery, ophthalmic artery, your internal carotid artery, and then we'll have your optic tract, which is your anterior choroidal, because it looks like your internal capsule. And then you'll have your lateral genicular nucleus, PCA, MCA, MCA, and PCA. Right, so blood supply is central retinal artery, ophthalmic artery, ICA, anterior choroidal, and PCA, MCA, PCA, and MCA. My slip. Pituitary adenoma, automoprogenals craniopharyngiomas from Rathke's cleft. So to form the pituitary, there's a downgrowth of your diencephalon and upgrowth of your stomatium. Forms an anterior and posterior to Rathke's cleft. So there's a stalk. Squamous cells, the pituitary stalk. It's craniopharyngioma, pituitary adenoma, craniopharyngioma, Rathke's cyst. It's from origination. So as we get that Rathke's pouch going out to diencephalon, craniopharyngioma, cella, meningioma, and ICA aneurysm. So the four differentials: pituitary adenoma, craniopharyngioma, Rathke's cleft cyst, ICA aneurysm, and cella meningioma. So what do we have here is your caudate, 26. Caudate, internal capsule, we have our lentiform nucleus, and we have our 19 corpus callosum, lateral ventricle, 32 your optic chiasm, 31 pituitary gland, underneath ICA. Sphenoid sinus, pituitary gland, ICA, pituitary stalk, optic chiasm, TSH, prolactin, growth hormone, cortisol, ptosis down and out, ocular motor palsy. Inferior oblique and diabetes, vascular conditions, aneurysms, chemotherapy, demyelinating disease, diabetes, giant cell arteritis, pilaritis will cause raised ICP, increase of fluid, Monro-Kelly doctrine. This mass is like a tumor, be edema, encephalitis, encephalopathies, be status epilepticus, choroid plexus, papilloma, meningitis, obstructive hydrocephalus. So Monro-Kelly doctrine principle: increase mass, tumor, abscess. And we can have cerebral edema, security meningitis, vasodilation, hypercapnia, is infarction, hydrocephalitis, meningitis, and decrease the choroplexus papilloma. Carry 1 malformations, syringomyelia, beaking of the tectoplate. The brainstem also herniated through. Type 2 is meant to cause hydrocephalus. Type 1 is where we get partial herniation. That's the lower brainstem. The fourth ventricle is now herniated downwards from the cerebellum, herniation of cerebellum and the flap. We get a lateral ventricle, a third ventricle, interventricular, lateral ventricle, third ventricle, cerebral aqueduct, fourth ventricle, spinal canal. Subarachnoid, vitals, closed angle, arteriovenous sinus thrombosis, vascular dissection, Terson's, tracheal bleed, pyeloid, hemorrhage. Subhyaloid. Subterson syndrome, knee tracheal bleed following raised ICU degree. Terson syndrome. Subhyaloid. Investigations, bleeding, decoax, lumbar puncture, coax, cerebral angiogram, contrast CT, full puncture, full vessel, CT. The physiology can be traumatic, berry aneurysms, vasodilation, pain, cerebral injury. Posterior cerebral artery, basilar artery, posterior cerebral, posterior communicating, middle cerebral, anterior cerebral, anterior communicating. You can see your basilar. Third ventricle, aqueduct, periaqueduct, cerebral aqueduct, fourth ventricle, central canal. Sterile meningitis, rupture, sterile meningitis, raised ICP, herniation, obstructive hydrocephalus, organization of fibrin in the subarachnoid space, delayed cerebral vasospasm can cause ischemia and hyponatremia. Volume depletion. Re-rupture, sterile meningitis, herniation syndromes, delayed vasospasm. Headache, nausea, vomiting, papilledema, compression of parasympathetic fibers, cause myelofibrosis, Cushing's triad, hyperbrady, hypertension, bradycardia, bradypnea, Cushing's triad, hypertension is to maintain mean arterial pressure and cerebral perfusion. This maintains pressure. And bradycardia is a compensatory parasympathetic upregulation. Epidural hemorrhage. biconvex, it's a well demarcated lesion and it does not cross suture lines. There is no obvious effacement and it's consistent with an epidural hematoma. It does not cross suture lines. Scalp bruising and hematoma. Scalp bruising could be blood from the fracture site, so it could be a depressed skull fracture, high risk infection. Blood seeping out from the hematoma. Blood seeping out of epidural space. Could be periosteum. Transtentorial, supratentorial, tentorial notch, blood peduncles, and corticospinal tract. Central, subfalcine, Tennessee strokes. So there's tonsillar herniations, there's breathing, and there is a transtentorial subfalcine herniations. There's central herniations, brainstem. Gums dispersed from the brainstem, cerebellum, tonsils. It's tonsillar central. Herniations is uncool or transtentorial. Blown pupil and cause hemiplegia. Signs as oculomotor nerve troubles in the transtentorial. Troubles leading superior colliculus. Middle meningeal artery. Shall also constitute a concussive effect as disruption of the reticular activating system. And then the neural recovery, and then hematoma increases it, and then and eventually will cause edema. Temporal bone, mastoid process, or canalize, or orbits can include meningitis, craniosynapses, scoscoma scale. Parasympathetic getting a western nucleus, the midbrain, superior colliculus, pierce the dura, the cavernous sinus, and superior orbital fissure, then pierce the dura, and then travel up superior orbital fissure, superior division to superior rectus inferior division. Inferior colliculus pierces the dura. Travels from the superior colliculus and travels through the cavernous sinus, the superior orbital fissure, and then give off to superior inferior division. It's a ciliary ganglion, ciliary nerves. From cavernous sinus, superior orbital fissure, and lower division. Ciliary ganglion. Lower division. Oculomotor nerve begins at the superior colliculus. There are two nuclei, the oculomotor nucleus and the Edinger-Westphal nucleus, and the motor fibers to the musculature of the eye originate from the somatic nucleus, and the Edinger-Westphal nucleus contributes to the parasympathetics. This will then travel through the cavernous sinus, out the superior orbital fissure, the cavernous sinus, then pierce the dura before traveling outside the superior orbital fissure. Pierce the dura that early? The dura is the skull. Dura lines the skull, so it must pierce the dura and it's traveling outside. So this is not right. So it travels the cavernous sinus, supraorbital fissure, piercing the dura, travels out, and gives off. No, that's two nuclei. Westphal. Synaptic nuclei and neurons. Project out. Travel. Cavernous sinus. And then they will travel out the supraorbital fissure. Fissure, and then they will synapse, super division, beta, palpebrae, superioris, superiorectus, inferior division. Ganglion, remaining muscles, trochlea, nerve, anatomy. Originates that inferior. Who then decusate and travel out. It originates through the cavernous sinus, supraorbital fissure, supraorbital inferior colliculus. It will decusate, travel in the cavernous sinus, and then it will out pierce dura, out supraorbital fissure, and supraorbital. And then we have our abducens. Cavernous sinus. Inducence is formed in your biliary junction, radial onto the biliary junction, and it will cavernous sinus, orbital fissure, supply lateral rectus. They all travel through the cavernous sinus. Travel ventilation. Aerobic control, respiration, medulla, input for synchronous. Pre-Botzinger complex. Keep for respiration. Let's project to the pacemaker with his inputs. Right, so we have pre-Botzinger complex, and medulla, and it sends outputs to the diaphragm, and thoracic muscles. Pre-Botzinger complex use inputs from stretch receptors and it receives outputs to stretch and chemoreceptors that need oxygen. Nucleus solitaris some baroreceptors and they project. Input tone from the limbic system. The way cardiorespiratory function works. Nucleus solitaris. And we have a pre-Botzinger complex. respiratory inputs. Some chemoreceptors. CO2. pH. pH and CO2. Outputs. Stretch receptors. They travel out and outputs to the lung, into the heart, chronic nerve. So the cardiorespiratory function, respiration, TRS, pacemaker cells, chemoreceptors, stretch receptors, C3, C5, and then thoracic control, muscles, current body, brainstem and spinal cord. So nucleus cell TARS, the pre-blood cell complex in the medulla. It's cardiac inputs and respiratory inputs and chemoreceptors and pulmonary stretch receptors. It's just a phrenic nerve which will travel to the lung and heart. It's a key principle here. The transverse ligament connects the atlas to the odontoid. You have your apical ligament, which connects your odontoid to your foramen magnum, your alar ligaments, which connect your odontoid to your atlas. Occipital condyles to the condyles, foramen magnum. Weakened leg, cerebral lego, which are diagnosis. Contralateral interclastrine arteries in the posterior lateral of the internal capsule. So the internal capsule has different supplies. There's an anterior limb. So you have our anterior thalamic radiation. Then we'll have our superior thalamic radiation, a corticobulbar and corticospinal tract, and we have an optic radiation there. So superior thalamic radiation and anterior thalamic radiation, superior thalamic radiation, and then posterior 2/3 of the anterior 2/3 of the posterior limb of the internal capsule is your corticospinal tract, and also your corticobulbar tract sits in the genu. Anterior 2/3, posterior limb of the internal capsule, and we have our genu. And the genu contains a corticobulbar tract. The genu is supplied by branches of the middle carotid, striate branches of ACA, MCA, and ICA. ACA, MCA, ICA. Anterior limb is your ACA and MCA. Striate branches of the ACA and MCA, and this is your coronary artery of Hübner, ACA, MCA, and then your posterior limb. This is Charcot artery of cerebral hemorrhage, and the anterior choroidal, MCA and anterior choroidal. Striate branches of the ACA, MCA. And then we have striate branches of the MCA and anterior choroidal artery, supplying the posterior 2/3. Yep. vascular arteriosclerosis, cerebral abscess, tumor, seizure, encephalitis, meningitis, abscess, tumor, seizure, stroke, basal ganglia, 23 is your flux cerebri, sense of personality, pituitary adenoma, we've gone through that. And then we have Chiari malformations, subarachnoid, epidural hemorrhage, non-contrast, work. What are different herniation syndromes? There's central, there's transtentorial, there's subfalcine, so corticospinal transtentorial, subfalcine cause ACA strokes, central, GCS, cavernous cardiac outputs, phrenic nerve into the heart as well. Increased contractility. Anatomy we've passed twice now. We'll come back to that, but pathology. With this MRI scan. Hyperdensity, so hemorrhagic stroke. Hypodensity ischemic stroke. Embolic or thrombotic. There's some problems. Basal ganglia as well. Jucavenasaurus. 4 midline structures, motor pathway, medial meniscus, MLF, lateral internuclear ophthalmoplegia, medial meniscus, motor pathway, motor nucleus and nerve, 4 lateral structures, spinocerebellar, spinothalamic, sensory, the 5th and sympathetic. So midline structures are motor, medial meniscus, MLF, There's 4 lateral structures, spinothalamic, spinocerebellar, sympathetic, cerebellum, central, lateral medullus, pathway, medial, LCAs, sensory nucleus, the 5th nerve, and sympathetic. Spinocerebellar, spinothalamic, sensory, spinocerebellar, spinothalamic. Spinocerebellar, spinothalamic, sensory. Parental control. Sensory, because the 5th trigeminal nerve, spinothalamic. That makes sense. Brainstem roller force. This is way more important than to move it. Go through breast cancer. Endocrine. I'll go through hypothyroidism. So I've done the. I need to go through. I'll go through Graves and hypothyroidism one more time, and then I'll go through fibrocystic change, breast cancer case, and then I'm done for today. And then I'll hit the gym. Graves' disease. Investigations that I performed, TFTs, anti-TSH receptor antibodies. Iodide enters through sodium iodide co-transport into the follicle. There's thyroglobulin secreted by thyrocytes. And then there's thyroid peroxidase, which does three things. It oxidizes iodide into iodine. But then iodinates it, forming diiodotyrosine and monoiodotyrosine. And there's conjugation where we attach to peroxidase binds iodine residues to tyrosine and then diiodotyrosine. Combine that conjugate monoiodotyrosine diiodotyrosine from T3 T4. Then we get exocytosis, cleavage of the thyroglobulin. Oxidizes iodination to these residues. So they're together from T3 T4. And then they cleaved. Thyroglobulin. Okay. So understand that. Thyroid structure, physiology, Graves, associated with HLA mutations, thyrotoxicosis, anti-TSH receptor antibodies, T3 T4 negative feedback, decreased TIH and TSH. Negative feedback on the anterior pituitary and hypothalamus. It's going to decrease TRH and TSH, that makes sense. And something that can affect thyroid hormone, cold, dopamine, somatostatin. Have negative feedback on both thyroid stimulating hormone as well. Hormone releasing hormone. Growth hormone. Estrogen stimulates it. Dietary decumulate. Has hypothyroidism, so it has increase in basal metabolic rate. It can activate cytochrome C oxidase, which increases respiratory enzymes, causes catecholamine excess, gluconeogenesis, lipolysis, proteolysis, beta-1, CNS, neurogenesis, and G. So how does hypothyroidism explain the symptoms? Patient's symptoms. Well, thyroid hormone acts on multiple receptors. It acts on nuclear receptors, increases the activity of the sodium, potassium, ATPase channels. And as a result, we can get increased basal metabolic rate, and that can result in increased heat. We may also get increased gluconeogenesis, proteolysis, lipolysis due to increased active induction of enzymes involved in cellular respiration, and that can result also in catecholamine excess. And we also have upregulation of beta-1 receptors, which increases heart rate, inotropy, chronotropy. And how do you get hypertension and tachycardia apart from sympathetic overactivation? We can get activation of beta-2 receptors, vasodilation. As T3, T4 can activate your beta-2 receptors, cause vasodilation, it can decrease renal perfusion, activate the renin-angiotensin-aldosterone system, and that can have direct increase to sympathetic outflow and also increase blood vessel caliber, causing hypertension. There's a thyroid storm. It's characterized as life-threatening medical emergency, and it's a massive increase of thyroid hormone. It can cause hypotension and predispose to tachyarrhythmias. It can be febrile, delirious, and treatment. Use thionamides to manage Graves' disease. So this includes propylthiouracil and carbimazole. Propylthiouracil and carbimazole have side effects: rash, urticaria, fever, arthralgia. Rash, urticaria, fever, arthralgia. Rare, they can cause cholestasis, agranulocytosis, and we can also consider radioiodide ablation, ectomy. What is your diagnosis? She complains of recent weight gain. time. We've got 5 minutes to do this case, and I also need to quickly go through the other case, and then I am going to head to the gym. You've beaten a cave. B is your aorta. C is your inferior mesenteric. Right rectus abdominis. And D. Oh, the Don Leota is awful. Carmeliac would play at all five. Modification of values. Affiliate crest. Junction of descending signal column. Hylian. guessing, what does obturator internus do? Adducts the hip. So where would it be? Yeah, so that should be it. Pudendal canal. I don't even know what the pudendal. I don't know. I don't, ooh. Ooh. 65%. Just horrendous. What happened? What did I miss? Oh, it tells it for me. Ah. So it tells me what everything is. How did I get that out? Up the levator reticularis. What was a clot mnemonic? Coagulation defect, levator reticularis obstetric, and thrombocytopenia. Coagulation defects, levator reticularis obstetric complications, and thrombocytopenia. Gotta first understand what the hell happened. Alright. So we need to connect. So E was your interventricular septum, D was your left ventricle, B was your esophagus, C was your esophagus vein, which is posterior to the esophagus, and A is your thoracic aorta. Your starting point was the esophagus. swear I got them all, did I not? I said F. I did say F. Let's see, was heterozygous? I said B. Yeah, I should have got all of them. But I didn't pick D. What was D? Cavity of the left ventricle. I forgot that one. Diaphragm level TV8. So the inferior vena cava is A. Well, that's the inferior vena cava. IVC. So left out of the diaphragm and stomach fundus. Stomach fundus and down with the diaphragm. I got that right. And then F, left atrium. Yep. D is your, got that right. E, is your right ventricle. Yeah. Come on, boy. Alright. Let's go. Start fundus and body. CIVC. D, thoracic aorta. E is the liver. C was the pylorus, got that right. D was the spleen, B was the body, A was the fundus. What was I? F was your gastrohepatic, and D was your caudate lobe. Pick that. Oh, I'm a bit off. Caudate is right here. It's on medial. The body, the pancreas. Got your F, which is a common hepatic artery. Got your D, which is the body of your pancreas. B, which is your right crus of your diaphragm. It's not behind there, so I'm not sure to say. That is your right crus. Portal vein, said with E. Damn, I even got that right. Sheesh. Not bad. So key point was the zygous, which I butchered completely. Hiatus TV12. Partially correct. Yes. F, D. D is completely wrong. D is splenic vein. D is there. Splenic vein is coming off the kidney. Kidney. page of sigmoid colon. D is your external iliac. C is your internal iliac. Posterior. Oh, let's see, wrong. What was C? C is your pudendal canal. So pudendal canal is between the shoulder muscle. Everything else is right. E was your external iliac. And your internal iliac would be there. Pudendal canal. It's between the femur and the bladder. Recent weight gain, fatigue, and menorrhagia. On examination, she appears pale. She speaks slowly. She has a diffusely enlarged non-tender thyroid gland. And she has a yellowish tinge on her skin. What is my diagnosis? My diagnosis is that of hypothyroidism. This could be secondary to Hashimoto's thyroiditis. This could also be secondary to exogenous causes of hypothyroidism, such as low iodine consumption. And then I'd like to also exclude other causes of menorrhagia, and this could include polycystic ovarian syndrome, endometriosis, any coagulopathies, potentially polyp or adenomyoses or tumors. However, I'm much more suspicious of thyroid pathology given her age, her goiter. This common cause, destructive lymphoid infiltrate in this fibrosis. It's primary, it could be iron deficiency, Hashimoto's, burnt out Graves, and subacute that I should mention. And there's also a post-thyroid ablation, decrease in nutritional consumption, amyotrophin and lithium. There can be amyloid as well, and lupus amyloid as well. And you can have tertiary Refetov syndrome. So as my diagnosis, I'm concerned about hypothyroidism. This can be due to Hashimoto's disease, also due to the burnt out phase of Graves' disease, and it can also be due to a subacute thyroiditis. I would like to also exclude other causes of thyroid deficiency, and this can include decreased nutritional consumption, increased, could be potentially medications such as amiodarone, lithium, potentially exclude other causes of dysmenorrhagia, and this could include polyps, adenomyosis, leiomyoma, other malignancies, and I'd like to exclude out coagulopathies, ovulatory disorders such as PCOS, endometriosis, polyps, adenomyosis, leiomyoma, malignancy, coagulopathy, ovarian dysfunction. So hypothyroidism, I consider the four main causes, which is Graves' disease, toxic multinodular goiter, acute phase of Hashimoto's, subacute thyroiditis. And in hypothyroidism, I'm concerned about Graves' disease and then burnt out concerned about Hashimoto's thyroiditis, burnt out Graves' disease, and subacute thyroiditis. I also like to exclude other causes, decrease consumption, other drugs such as amiodarone and lithium, and what else is there? Burnt out phase, lithium, and Graves' disease, Hashimoto's, and what else is there? Amyloidosis. Yeah, amyloidosis, and then also you consider your pituitary causes. What I do, TFTs, and given that concern about Graves, we can do 3. We do antithyroid peroxidase, antithyroid globulin, and anti-nuclear factor. Okay, so anti-nuclear factor, antithyroid globulin, antithyroid peroxidase. We do anti-TSH antibodies for Graves, but this is antithyroid peroxidase, antithyroid globulin. Do ultrasound, find elaspirate, and given that concern, like to exclude for fatigue anemia as well as a differential. This is the management of hypothyroidism. We use levothyroxine. So we use propylthiouracil, or we use your thionamide such as carbimazole for how do they work? Thyroid peroxidase inhibitor, propylthiouracil thyroid peroxidase inhibitor. Okay, and then this is levothyroxine, which is just additional thyroxine, and it's contraindicated in adrenal. Save adrenal insufficiency, build up T4. So levothyroxine can be used, but we would not want to use it in adrenal insufficiency. However, as we can have impaired conversion of T4 to T3, and that can build up to toxic levels. What are the clinical manifestations of hypothyroidism? Graves' disease. Proptosis, fibroblast proliferation. T4. So it can occur with low circulating T3, T4, and it could be due to cytokines, which can cause abnormalities in clearance of thyroid hormone and its function, cause low T3, T4, which you have to treat the underlying cause. Altering the sick. That releases cytokines that impairs iodination. Patient continues profound fatigue, deep blunted, deep tendon reflexes, sinus bradycardia, reduced sodium levels. Why is there There's a change to cycling T3, T4 without underlying thyroid hormone pathology. It can be due to some kind of infection, which can impair the function and clearance of T3, T4 due to cytokines, and we have low T3 and low TSH and T4. And you can use thyroid hormone replacement, but you must treat the underlying cause if the patient is acute severe illness. Decreasing perfusion. So why do they get hyponatremia? It's decreased cardiac output, decreases renal perfusion, is increased aldosterone that causes sodium reabsorption, which causes sodium reabsorption, potassium secretion. But it's a massive water retention and you get dilutional hyponatremia. So aldosterone, water retention, decreased renal perfusion. So why do you get hyponatremia in Graves'? It's because it's decreased renal perfusion, which leads to increased aldosterone activation through the RAS pathway, which increases water reabsorption, dilutional hyponatremia. There's a complication of hypothyroidism. This is myxedema coma. So we had thyroid storm. This is myxedema coma, splunted deep tendon reflexes, decreased mental status. There is decreased T4, and this is ventilation IV dextrose. Could be a severe hypothyroidism complicated by trauma, sepsis, a severely reduced metabolic rate, decreased oxygen consumption. There can be overdose of other medications, and that can predispose to myxedema coma. Medical emergency, and decreased oxygen consumption, and could be implicated by, we read myxedema coma and BMJ. Hypothermia, hyperventilation, glucose, levothyroxine, corticosteroids. Hypophysiology, Hashimoto's, we get reflexes, metasolutionness. So lymphocytic infiltrate and which leads to follicular destruction. And this causes atrophy of follicles and lymphocytic infiltration, follicular destruction, loss of colloid, and there's fibrosis. And it's usually non-tender and it's treated with levothyroxine, subacute. Initial thyrotoxicosis, and then it causes a hypothyroidism, and it can settle as a euthyroidism, just thyroiditis. There's giant cells, lymphocytes that release the stored hormone. So we get decoy veins, which is painful, and then silent, which is postpartum. And there's also other autoimmune, postpartum autoimmune or lymphocytic subacute. So when you think subacute thyroiditis, you could consider there is a postpartum. There is, when you think subacute thyroiditis, you think decoy veins, which is painful, and then you consider other causes such as postpartum autoimmune and lymphocytic, preceded by viral ERT. And then you get pain, you can add NSAIDs during the treatment, and postpartum, so lymphocytic, and then beta blockers, thyrotoxic case, and then you can consider thyroxine. severe case of hypothyroidism to myxedema coma. Last thing we'll talk about is breast cancer. Let's quickly do this. Breast cancer. If you're noticing a lump in her breast, had it removed, it's firm, non-tender, and the attachment to deeper structures. There's no axillary lymphadenopathy. She has neck pain and weakness in her left upper limb. She had weak elbow flexion, and loss of pain was present in her right index finger and the ulnar aspect of her wrist. Breast neoplasm with metastases too. She has issues with elbow flexion. So that's C5, C6. And there's loss of pain in her right index finger. It could be fibrocystic change, breast abscess, mastitis, and then you think you're benign. So what are your diagnoses? Some room, psychonophthal. I just have room in genitourinary, obstetric or genitourinary. But tomorrow I'm gonna smash most of that out. So for obstetrics and gynecology, got our anatomy for breast cancer, your diagnosis. Is the differentials here? So I'm concerned about infective causes, fibrocystic change. It can be cystadenosis. It can be ductal hyperplasia. It can be abscess, mastitis, fat necrosis, mammary ductictasia. It can be a fat necrosis, abscess, mastitis. It can be fibrosis, cysts, adenosis. It can be hyperplasia. It can be a fibroadenoma or a papilloma, intraductal fibroadenoma or intraductal papilloma, and that can progress to a lobular carcinoma in situ or ductal carcinoma in situ. Invasive ductal carcinoma, 70%. Invasive ductal carcinoma. Paget's disease of the nipple. What the hell is Paget's disease of the nipple? I've heard this so many times. Okay, maybe I should not Google search that, given the graphic images. Eczema-like changes that can signify that there is a malignancy. So my differentials, my diagnosis and differentials include given the patient's age, given that there's a lump with symptoms of invasion, I'm concerned about malignancy. This could be a ductal lobular carcinoma, and I'd like to also exclude other causes such as infective causes, a mastitis, abscess, inflammatory causes such as mammary ductictasia, fat necrosis, mammary ductictasia, and then benign pathologies that could include fibrocystic change, and then potentially pre-malignant pathologies such as hyperplasia, and then papillomas or adenomas of the breast that could then proceed to lobular carcinoma and ductal carcinoma in situ. Upper motor neuron lesions is the first motor neuron of the corticospinal tract, and then second. So you have muscle wasting, fasciculations, hypo everything from the anterior horn. Dermatomes of the myotomes of the upper limb. Finger abduction is ulnar nerve. Wrist flexion is the ulnar and median. So how do you test your median nerve? So your median nerve is finger flexion. Wrist extension is your radial. Wrist flexion is ulnar and median. And abduction is ulnar nerve. Finger abduction is CAT1 ulnar nerve. So look at your movement, your myotome. C5C6 causes your shoulder abductions via the axillary nerve, and adduction is through the pectoral nerves. And then we have flexion, C5-6, which is your muscular cutaneous nerve. Extension is your radial nerve. Wrist extension is your radial nerve. Flexion is your flexor carpi ulnaris radialis, C6-7. So much anatomy, holy shit. Corticospinal tract, spinothalamic is a deficits in pain and temperature. They descend a couple of fragments in dorsolateral tract of the cervix entering and synapsing the dorsal horn, technoid neuron, dorsal horn. Holy shit. What is spinothalamic? First sort of neuron, dorsal horn, decussation, and spinothalamic. Dorsal horn, it will synapse across and then travel through the white matter dorsolateral tract. And then across the ventral white commissure and synapse the dorsal horn. Then it will synapse, travel across the ventral white commissure, central canal, and cholesterol, the ventral. They then travel through the spinal cord. Stupid ass text. Corticospinal. Corticospinal is via the primary somatosensory cortex. It travels to the anterior 2/3 posterior limb, the internal capsule. Before then it will travel through the medulla, decussate, and 85% will decussate, and then it will synapse the anterior horn. There's a second neuron. And then we also have your primary and then we have our spinothalamic tract. Spinothalamic tract. And this is from periphery to second. Ventral roots, ventral rami, to the body. Spinothalamic is from set to dorsal root ganglion to dorsolateral tract. Spinal cord. Second neuron is then going to decussate behind spinal canal in the ventral white commissure. Ascends to VPO, thalamus, and the third order neuron travels from VPL nucleus of thalamus to primary somatosensory cortex. And your corticospinal is your primary motor cortex. Thoracic and vertebral. Tell the difference between thoracic and cervical vertebra. Cervical vertebra is small, larger, largest. There's one vertebral. There's two transverse foramina. And it's typically bifid in nature. Transverse processes become larger and larger. And their articular facets for ribs are present only for thoracic size. So cervical, thoracic, and lumbar is based on morphology. Cervical is bifid. They have foramina transversaria. The actual size is smallest to largest. Your thoracic vertebra is larger, it's thicker. Lumbar is the largest. And the size of there are articulating facets only on thoracic vertebra, and bifid, long, so short and blunt. And the size is thickest, thick and thin. The disc. For the risk factors for breast cancer, hormone replacement therapy, nulliparity, age, family history, early menarche, late menopause, genetics, early menarche, late menopause, nulliparity, decrease. Anatomy. Don't need to do the other one. Risk factors. Shoulder abduction is via the axillary nerve. Shoulder adduction is C6, 7, and 8. In terms of the upper limb is we've got C4 over the shoulder, C5 over the lateral biceps, C6 is your thumb, C7 is your index finger, C8 is the pinky, C6, 7, 8, and then T1 and T2 is the armpit. So C5, C4 is the deltoid, C3 is your trapezius, C4 is the deltoid, C5 is the lateral bicep, C6 is the index, C7 is the thumb, C7 is the index, C8 is your pinky finger, and then T1 and T2 is the armpit area. So what else can we talk about? Shoulder abduction is characterized by the axillary nerve, it's 5, 6, and then 5, 6 is also pick up sticks. Adduction is 6, 7, 8. Deduction has a bunch of D's, so 6, 7, 8. and then 6, 7, 8, and then elbow flexion is 5, 6. It's a muscular cutaneous nerve. Extension, shoulder adduction is your pectoral nerves. Elbow extension is your radial nerve. Wrist flexion is your median nerve. Wrist extension is radial nerve. Elbow flexion is 5, 6. Elbow extension is 7, 8. Wrist flexion is 6, 7. Finger flexion is also 5, 6, 6, 7, 7, 8, and 8 T1. Adduction is median. Adduction is ulnar nerve. Finger extension is radial. Flexion extension are the same. And wrist extension. Okay, let me try answering this. What are the patterns here, right? I need to quickly write this down. I'm starving right now. Done 8 hours of study, non-stop pretty much. Let's go. Myotomes. 1. With the arm. So for the arm, the trapezius, that's C4. Then we've got deltoid, C5, lateral bicep, C6, and then C7. C3, it's going to be C3, C4, C5, C6, C7, C8, T1, T2, and then myotomes, 5, 6. Abduction, shoulder abduction, C5, 6, axillary, 5, 6, shoulder adduction, C6, 7, 8. It's pectoral nerves. These. These pecs. Too many D's. Too many numbers. And these pecs. And then I'm going to remember 1, 2 is flexion, elbow flexion. Elbow flexion is C5, 6. And it's via the muscular cutaneous nerve. It's via the musculocutaneous nerve. It's 5, 6. Pick up sticks. Sticks. And before, it's going to be wrist flexion. Flexion is going to be C6, extension. Then we have elbow extension. Elbow extension is going to be C7, 8. And it's going to be radial nerve. 7, 8 to lay them straight. And then we have finger flexion or wrist flexion. Wrist flexion is C6, 7. It's median nerve. Elbow flexion plus 1. 5, 6 plus 1 plus 1. And then wrist extension. Is radial nerve. What is wrist extension? C7, C8. Wrist flexion is C7, C8. Same as tries. And then finger flexion. Finger extension is C7, C8, and this is median, and this is radial, and then your abduction, finger abduction, and finally we have finger abduction. Abduction. Then we have finger adduction. Adduction. Finger adduction and abduction. C8, T1. And ulna is abduction and adduction is median. And this is going to get screenshotted. Put in my notes. I've gone through the breast anatomy case. It's the first of the anatomies. Affected thoracic and cervical vertebra. Yes, you can. Your cervical vertebra tend to be bifid in nature. They just have multiple foramina, such as your vertebral foramina from foramina transversaria. The thoracic only have your one vertebra, which is the spinal vertebra for the spinal canal, and so the foramen for the spinal canal. Thoracic vertebra also have large spinous processes, and they also have articulating facets. Factors: hormone replacement therapy, obesity is a hyperestrogenic state, smoking, and then nulliparity, or pregnancy can be protective as long as it's young in pregnancy. carcinoma, radiation, potential viruses, modifiable. What are the key differences? Well, the cervical vertebra and this is the thoracic vertebra. The cervical vertebra has foramina transversaria smaller, as your thoracic has larger, good articulating facets, smaller, and bifid spinous process. Done. So that's cervical cancer, ovarian cancer. Then I have the PAT stations. 1, 2, 3, 4. Five, 6, 7. Eight, 9, 10, 11, 12 cases. Can I do 12 cases all tomorrow? Let's find out. I'm finished my first round of cover. It's not bad. Just need to make sure I remember all this. Just go back. What's plaguing my mind is neurology. What's the path? They always ask what the pathophysiological changes are. Here's the ICP, another stroke, aspiration, pneumonia, pressure sore, inflammation, pathogenesis, molecular events. So we get softening, blurring of the great white matter junction. We can get edema and a thin walled cyst and thickened meninges. So we get reactive gliosis. So we see no abnormality, red neurons, place of liquefactive necrosis, due to changes in swelling, neurotransmitters, and they cause activation of NMDA receptors, and this causes, and this increases calcium, swelling, depolarization, NMDA receptors, and this causes increased calcium, and this causes NMDA receptors, increased calcium activates phospholipases, forms free radicals, and they damage cell membranes, and they cause liquefactive necrosis. Right. So what's the pathophysiology? Well, there is impairment of sodium, potassium, ATPase is pumped, and what happens is we get swelling of neurons, we get depolarization, glutamate binds to NMDA receptors, causes calcium influx, that causes further depolarization, eventually selective phospholipases that will damage produce free radicals, damage components of the cell, causing a liquefactive necrosis. So initially you have no changes, then a blurring of the great white matter junction, then edema, and then a thin-rimmed cyst with thickened meninges, liquefactive necrosis. We'll see red neurons and glial fibers. So initially, we will see within one day, we'll see red neurons, no abnormality detected. What are these red neurons? Neuro, yeah. Red. See red neurons. Or eosinophilic neurons occur secondary to injured apoptotic neurons. chronic neurons. And we'll see some neutrophils, and then 2 or 3 days we'll see blaring of the great white matter junction, see liquefactive necrosis, and then reactive astrocytosis within days, and then we'll start to see edema. The edema will begin to decrease, and we'll start to see gliosis occurring, and then we'll have a cyst with glial fibrils and macrophages. So what are the changes in stroke? So within the first 24 hours, we would observe macroscopically there would be no change, and we would identify potentially red neurons and some occasional neutrophils. Within 1 to 3 days, we would then see blurring of the great white matter junction, softening of that tissue in the brain, and the onset of edema, blurring of the great white matter junction and edema. And at a cellular level, we're getting liquefactive necrosis, initial gliosis procedure, and reactive astrocytes. Not gliosis yet, reactive astrocytes. They're going to initiate gliosis, and then in approximately 1 month, we would see gliosis and edema would have begun to decrease. And then within months to years, let's break this down together. The renal changes. Hyaline arteriosclerosis, Camden embolic, systemic hyperperfusion, Camden hyaline arteriosclerosis, intracerebral could be extracerebral emboli, could be atherosclerosis, hyaline arteriosclerosis in smaller vessels, and then embolic strokes. So it could be thrombotic or embolic strokes. Thrombotic make up the vast majority, and embolic strokes make up 15%. Rare, you can have systemic hyperperfusion, and thrombotic can be due to hyaline arteriosclerosis and ischemia, acute influx. No changes in stroke within 24 hours, 1 day, 24 hours, 1 day, macroscopic. We'll rearrange this to macroscopic and macroscopic. So macroscopic and then microscopic. So in 1 day, what we would see is nil, and then we'd see red or injured neurons, necrotic neurons, red or necrotic neurons. And see occasional neutrophils. And then we could do 1 to 3 days. We'd see blurring of the great white matter junction, of the gray white matter junction, and then microscopically we would see liquefactive necrosis, and reactive astrocytosis. Cytosis occurring, and then about weeks to a month with the decrease in edema, and would see gliosis. Right, so astrocytes repairing. Another 1+ month. Begin to see thin, rimmed cyst with plus thickened meninges. With thickened meninges, and that's gliosis. And then we'd see that's it. What else do you see? Yeah, gliosis plus macrophages. Same thing, plus macrophages. your fibers, your macrophages. That's what we see. Write it the way I like to not. Oh my lord, I've done 8.5 hours. I am peeved. I need to hit the gym. It's been ages and I need to exercise or I will feel imbalanced. So, thanks for joining. Hope you all got some work done. I got a ton of work done. So I'm happy. Catch you all later.